क्या हुआ ललित sir?
Bye.
Mute. You are muted. After yesterday's this thing, but day before yesterday you were not there. 8:30. It went on till 11:30.
We're going to go on.
Sir, you are muted. You are muted.
Unmute yourself.
Those sessions are for Dr. Chitra and Santosh on our.
We are live, please.
Okay. Very good evening to one and all of you for this ARC PG update webinar on retina today. We are lucky to have the choicest of expert panel and a very capable set of speakers and some very relevant topics which have been beautifully laid out to keep us all bound to our seats. We have on our panel Dr. N.S. Muralidhar, who would be joining anytime now, who is the president of the Retina Institute of Karnataka, a leader amongst leaders in retina, the senior most retina specialist in Karnataka to be reckoned with, and has this array of awards and recognitions. We have with us Dr. Dinesh Talwar, senior consultant ophthalmologist and senior specialist vitreoretina and uveal disorders from CFS Delhi, who has held many honoris posts with great recognitions and tributes. We have with us Dr. Lalit Verma, who has held the most highly coveted posts which AIOS could ever have, has left an indelible mark as a chairman scientific committee for his 6-year term, has brought in many initiatives that has bound the entire AIOS together, has 172 publications, innumerable awards and orations to his credit. Dr. Guru Prasad, our esteemed expert speak panel, is the Director of Clinical Services and Head of Vitreoretina Services of M.M. Joshi Eye Hospitals, with a great presence in North Karnataka, a path breaker in the number of surgeries performed, and of course, ever increasing numbers. We have with us Dr. Jatinder Singh, Senior Consultant Vitreoretina and Uvea Services at the Coimbatore branch of the Eye Foundation Group of Hospitals, a surgeon par excellence in dealing with the most complex surgeries, astute, knowledgeable, and has trained postgraduates and retina fellows over 15 years, evolving the curriculum with major contributions in publications and more. I have none other than Dr. Srinivas Joshi moderating with me with his fiery energy to get the best out of this webinar, and let's watch on. Besides being an amazingly skilled surgeon with very impressive academic career, his area of interest has been artificial retina, one of the first Indians to be trained in this complex field with some of the most impressive awards, I'm not listing them, received at a very young age, which reflects his brilliance. He's also the member ARC South with a brilliant future ahead. So we shall now go on to our great speakers. The first one is the section on how to read. And our first speaker is Dr. Neha Goel, who would elaborate on how to read the OCT. So the postgraduates and other ophthalmologists watch on. She's currently a senior consultant vitreoretina surgeon at Max Multi-Speciality Hospital, New Delhi, and has a keen interest in academics with over 90 PubMed index publications in the field of vitreoretina. On to you, Dr. Neha.
Thank you, Dr. Chitra, and I thank AIOS, especially Dr. Srinivas, for giving me this opportunity. So I'm going to talk for the next 8 minutes about how to read an OCT, which is the most commonly performed investigation, not just in retina, medical retina, but pan-ophthalmology. As we know, it's a non-invasive, non-contact method of examination of the retinal layers. And we've been witness to these generations of OCT, which started with time domain and are now up to sweat source with basic changes in the resolution. So this is how the image has changed over the last 2 decades, as we've been seeing time domain, spectral domain, ultra high resolution, and now the sweat source. And what is it that actually makes these generations different? The sweat source differs in wavelength, which is longer, 1050, and the spectral domain and time domain differ in the detector, as in the spectrometer. Now, this translates into greater number of A scans per second, a longer scan length, and then consequently the better resolution. So the interpretation of an OCT image basically talks about the reflectivity, which is the proportion of light which is backscattered by a tissue in addition to being absorbed or transmitted. We have structures which are hyperreflective and those which are hyporeflective, and this is what we talk about when we read a report. These are the normal retinal layers which you would see in a spectralis OCT, and the nomenclature has been given by the International Society. So when we read a report, we usually talk about the vitreoretinal interface, the retinal architecture, and then the RP choriocapillaris complex. And with enhanced resolution, we also talk about the vitreous as well as the choroid and even the choroid scleral junction. Let's look at the normal first. This is a normal swept source OCT image. Here you see a slight bulge beneath the fovea, which is supposed to be the elongated tips of the photoreceptors, outer tips, which is normal, a blood vessel leading to shadowing, and always remember to check what is the direction and the length of the scan. Now, starting with the vitreous, this is the normal vitreous where you have the precortical vitreous pocket, the Cloppett's canal, and a one-way valve, which is now beautifully demonstrated by your swept source OCT. Let's read these two OCTs. Both of them show hyperreflectivity in the vitreous. What is it? You have to look clinically. One is vitreous cells, while the other is a vitreous bleed. What about this one? The hyperreflectivity seems to be on both sides of the macula. So this is a classic picture of asteroid hyalosis where you get a mirror artifact. Next, we go to the VR interface, where again, the stages of PVD can be beautifully demonstrated by the OCT. We must be able to recognize a vitreomacular adhesion, where the foveal contour is normal, and a vitreomacular traction, where the foveal contour gets obliterated. Now, full thickness macular holes, OCT is of course indispensable for the diagnosis, and you can stage it as per the GAS classification with regards to the size and the absence or presence of PVD. When you read a OCT in a macular hole case, be sure to mention these indices, the macular hole index and the hole form factor, both of which have a bearing on the visual prognostication post-surgery. Hole closure can be seen in different ways. The top two are the ones we usually see, whereas the lower two should also not be mistaken for non-closure. Now, question time. I know we are short of time, but what does this look to you like? And you might very well get it in an exam. So here you see there is a discontinuity in the neurosensory retina. So is it just a macular hole? No. If you look carefully, you can't see the RP choriocapillaris complex here. And the reason is that because the retina is detached, and this is actually a case of high myopia. So my tip here would be that whenever you get an OCT to read, please first mention the findings and don't jump straight to the diagnosis that this is a macular hole. When you read out the findings, you'll be able to reach the better diagnosis yourself. Epiretinal membranes are hyperreflective lines seen at the vitreoretinal interface, which can be attached focally or globally. Let's look at some other holes now. A pseudo hole where you have a steep configuration of the walls, and a lamellar hole where you have an inverted mushroom shape. This should be differentiated from the lamellar hole associated epiretinal proliferation, as you can see from the arrows, and also from an outer lamellar hole, which you basically just get in two conditions, a solar retinopathy or a dysptic maculopathy. Now, when you mention about the interface, also do talk about the foveal contour, which can be obliterated basically because it's hyperplastic, it's being pulled, pushed, or a combined mechanism. Third, we come to the retinal architecture, which we commonly see as fluid, which may be intraretinal or subretinal, may be accompanied by hard exudates. Diabetic macular edema, you are very likely to get an OCT of this. And when you read this, do look at the central foveal thickness to determine whether it is center involving or non-center involving. Now, most of the cutoff is around 300 microns. OCT in DME also interestingly tells us a lot about the biomarkers, where we look at these 4 layers, and these are said to corroborate with the visual acuity, not just in DME, but a host of other macular disorders. Drill is another feature which you can mention, the disorganization of the retinal inner layers, which is again a biomarker. But please remember that these do not work if the edema is too much. Now look at these 2 scans. Yes, it's edema, but what else? The one on your left shows inner retinal hyperreflectivity, which is indicative of ischemia, even when you read the OCT. And the other one shows a predominantly one-sided edema, with again will point to a retinal vascular occlusion. Another question, what investigation will you order when you see this OCT? Now, you'll be very tempted to say FFA, but look carefully. This is not edema, this is chysis, which you can see in X-linked retinoschisis or even in dysptic maculopathy. Now, how to differentiate? You see these typical pillars at the level of the inner nuclear layer, which give it a ladder appearance. And of course, the fundus examination clinches the diagnosis. Another condition where you get chysis is the high myopic tractional maculopathy, where it may or may not be accompanied by a subfoveal detachment. This will again be apparent on clinical examination. Let's look at this and read this OCT. What do you see? The EZ is only present subfoveally. It's absent elsewhere. What would your guess be? This is the AF, another hint, the Robson-Holder ring. So this is a typical case of RP where you see only the end photoreceptors are left in the subfoveal region. Another dystrophy with the OCT, here you see the defect in the photoreceptor, which also points towards the diagnosis of cone dystrophy when you read this OCT. Now, this is the last part of the retinal architecture, MACTEL or macular telangiectasia, an important disorder to recognize where you see mismatch between the angiographic leakage and the thickness on the OCT. And you might very well get this OCT to read where you have to say you see either the inner or outer hyporeflective cavities, sometimes accompanied by this typical ILM drape, a collapse of the outer retina in the later stages with foveal thinning and the pigment. Now, fourth, we come to the RP choriocapillaris complex. The commonest disorder we see here are drusen, which may be hard, soft,
1 minute left,
or the subretinal drusenoid deposits called the pseudodrusen. Geographic atrophy, again, a striking feature. And the PEDs, this again you can get to read. So how do you differentiate them? In serous, you have an optically clear space, which becomes echogenic in fibrovascular. You see a distinct band of the choroid in serous, which is again absent due to the shadowing effect in hemorrhagic. And you must remember that while the top two are non-neovascular, the bottom three are the ones you see in neovascular AMD. Type 1 CNVM, which is sub-RP, type 2, which is subretinal and has a better prognosis. And let's look at this, another question. Is this a CNVM? No, if you look carefully, the line of the RP choriocapillaris is intact and there is hyper-AF suggesting to a vitelliform lesion. Type 3 will show you a serous PED with CME, and PCV, now more and more we are going towards the OCT diagnosis as well. When you read this OCT, you see there's a discontinuity in the RP pointing towards a RPE rip. The last part is OCT in CSC, where we can easily recognize the PD and the NSD for diagnosis and monitoring. What additional you can read in this OCT is the posterior surface. The more granulated it is, the more duration and the poorer prognosis it points towards. Another pointer in the OCT is the site of the leak. Sometimes you can get this PED with the sagging or dipping of the neurosensory retina and this vacuole sign, which suggests that it might even be steroid induced. What is this? It looks very much like a CSC, but again, always corroborate clinically. This is actually a pseudohypopion in Best disease. And this is an important thing I'd like to end with. What will you do next when you see this OCT picture? And I actually got this in my PG exam about 15 years back. I said FFA, and Dr. S.P. Garg looked at me very sternly and said, please look again. So the key here is that you cannot see the extent of the neurosensory detachment. So what you should do next is a distant direct ophthalmoscopy, because what you might be looking at is an RD and not a CSC. Similarly, another case where you see these outer retinal folds, again, typical of a RD and not a central serous chorioretinopathy. The last part about the choroid, I'll just mention that it's important to look for, because you can pick up pachychoroid diseases, BKH, and of course, choroidal neoplasms. And choroidal thickness must always be correlated with age. As we know, it grows thinner with age, and in PCV, it will be thinner as compared to a patient with RAP or pseudodrusen. So this is basically a word about the pachychoroid diseases, where you see dilatation of the larger choroidal vessels and loss of the small and medium vessels. And these pachy vessels can also be seen. If you compare with normal, it's very obvious. Compare this with the choroiditis or BKH, where there is diffuse thickening of all the layers, maybe accompanied by a wavy choroid or a elevation. Now, the last slide about the clinical pearls, whether to do radial or raster. So the consensus is that in all diseases except neovascular AMD, radial is comparable to raster and has the advantage of being faster. Look at this OCT. If you get this in the exam, what are you going to say? Just like an FFA, you should ask for more films, because sometimes what looks like an edema might actually be a macular hole. So if you look at the consecutive films, you'll see this is actually a defect in the neurosensory retina. So to conclude, OCT is indispensable for the diagnosis, monitoring, and prognosis of virtually all retinal disorders. It gives us quantitative measurements, and in accordance with NFAS and OCT angio, it provides us a wealth of information. But the eyes only see what the mind knows, so a good knowledge of the subject is irreplaceable. Thank you.
Wonderful talk, Neha, just absolutely wonderful. So I'll ask one very simple PG question and Srinivas will attack you more. So how would you differentiate, for the PGs, how would you differentiate a post-op CME from a diabetic macular edema on OCT?
So a very good and very relevant question. So like I had shown, sometimes in diabetic macular edema, you can have associated hard exudates, which you will not get in the pseudophakic CME. Also, the pseudophakic CME is usually more evenly distributed around the fovea as compared to a diabetic, which may sometimes be focal. But then finally, I would say that FFA would help you because you would get staining at the optic nerve head also in the pseudophakic CME because of breakdown of the blood-vitreous barrier, which you will not get in a diabetic unless there is NVD, which is again clear evidently.
Anything more to add?
Thank you, Dr. Neha. I think you have covered most of the topics in just 8 to 9 minutes. I think it's really awesome presentation. Thank you. And very good pictures you have used, and with the case pearls also in this short time. Thank you very much. I had one question. See, most of our postgraduates or the younger ophthalmologists, vitreoretinal surgeon, they ask, there are so many in the macular hole. You have macular hole index, you have hole form factor, you have tractional hole index, you have macular hole volume, you have diametric hole index. So what are these important things they need to know, or they need to know everything from the exam point of view? Even when you showed the ERM pictures, do they need to know about the staging of ERM as well for passing the DNB or the MS exams?
So starting with macular hole, I showed the two which we commonly use clinically and, which should be known. It is desirable, though it is not absolutely necessary, the macular hole index and the hole form factor. So these two, I think if you know these and you are able to say this should be enough to pass very comfortably. Of course, for your interest, all the ones you mentioned can be looked at. Similarly, for epiretinal membrane, yes, I did not show that classification because of, want of time. But it actually involves the ectopic inner foveal layers also, which is a relatively new concept even for DR specialists. So I wouldn't, penalize a PG for not knowing that. So it's more important that they recognize it clinically and, they understand the pathophysiology and all of that. So staging, yes, again, desirable, but these are, I would not say that these are must know for the exam.
Nice answer. Yes, I'd like to ask our moderator, Jatinder sir. Can you just unmute yourself?
Yeah, no, just one point to answer Dr. Chitra's question. To differentiate edema CME in a diabetic patient who has some macular but no deposits at macula, compared to a patient who is having a pseudophakic CME, you can do a peripapillary nerve fiber layer thickness. And this is what I've been using to differentiate the two. And I think it's pretty accurate. If the RNFL is thickened, it indicates more of an inflammatory etiology, that is post-op CME, versus DME case where the RNFL thickness is more or less comparable to the fellow eye. So this also helps to guide and target your therapy accordingly, because for a pseudophakic CME, you can just treat with peribulbous steroids, whereas for a center involving DME in the form of cystoid edema, you still have to go with anti-VEGF.
Yes, quick points from Lalit sir, and then we can move on to the next topic.
Wonderful presentation. It's an injustice that you have asked her to present in 8 minutes a full book of OCT. That was the first comment. The second very good point Neha made was none of the interpreters should jump on one frame. She emphasized very nicely. And second is go layer by layer in interpretation. Never jump to diagnosis on OCT frame unless it is very obvious. Go layer by layer, whether RP is intact or not, what is happening to inner retina, what is happening to outer retina. So classify interface, outer retina, inner retina. And then I think diagnosis will become simpler.
Probably that way, pseudophakic CME would also affect the inner nuclear layer first, then a DME and outer. That would also be
that is the reason, because from ILM till ERM, it is inner retina. From ERM to RPE, it is outer retina. So that is the, and interfaces where vitreous meets the ILM. So all the PGs should classify there's inner retinal disease, outer retinal. Outer retinal would typically mean ARMD, PCVs, and other things. Inner retina, all the inflammatory pathologies, RVOs and DMEs and other things. And Jati made a very relevant point that you see RNFL measurement, we primarily go with inflammatory pathologies.
Thank you,
so
sir.
one more thing I think I would like to add is the PGs should refrain from offering a diagnosis or exact etiological diagnosis, but just by seeing any imaging, not just OCT, but any even FFA ultrasound. They should just highlight the features like hyperreflectivity, the configuration, the location of the lesion, rather than just saying that it is detachment or CS or any other point diagnosis.
Very, very good point, sir. Yeah, true. And we welcome Dr. N.S. Muralidhar, sir, also to this thing. And
Yes,
I think the
hello.
next speaker, he can just answer people.
We shall then go on to our next speaker, Khan, who is going to be elaborating on reading the FFA. He's a prolific vitreoretina surgeon from Sachitana Eyes Clinic. I don't know if I'm pronouncing it right. And with an expertise in diabetic retinopathy and retinal detachment. On to you, Dr. Shrikant.
Yes, thank you, ma'am. Yes. Hope the screen is visible.
Not yet.
Not yet. Okay.
Yeah.
Okay, so this is a short talk on interpretation of a fluorescein angiogram. And as you see, when you see a color fundus photograph, you might see a lot of red and orange and yellow, but a lot of details that we could miss. And the sepia tones sometimes reveal a lot of information which we would have otherwise missed, like neovascularization and a lot of microaneurysms in the perimacular area. And decoding the sepia tones is what we are going to learn today. So the main difference between looking at a fundus photograph and doing a fluorescein angiogram is the FFA is a time-bound test. So our photography skills and capturing of the images and timing is absolutely crucial. And on the right side, you can see a live FFA video that we have taken on an HRA, and this is how fast the angiogram FFA progresses from early choroidal phase to an AV phase and recirculation phase within a matter of 40 seconds. So capturing the images, concentrating on getting good quality photographs as a postgraduate is more important than trying to make a diagnosis while you are capturing the images from a PG point of view. Some trivia: this was discovered in 1959 by Novotny and Alvis, and they tested first on rabbits that there is an emission spectrum and an absorption spectrum, which is 480 and 520 nanometers. And finally, one of these scientists was the first human guinea pig to undergo the fluorescein angiogram, and they tested it on themselves. That's how confident they were about their test. So there is a blue excitation and a green barrier filter, which blocks the abnormal fluorescence and allows only the fluorescence from the structures to pass through and follow the camera sensor. The phases of the fluorescein angiogram: there is an early choroidal phase, which is within the first 10 seconds. And this is a diffuse background choroidal flush where the entire choroid glows up, and you can see some areas of choroidal infarct as a dark patch. And the arterial phase lasts for a very short 3 seconds, and the arteries fill up with the background of the choroidal flush. And then there is an AV phase, which is further broken down into a early AV and a late AV phase. This is the phase where we are going to look at the foveal avascular zone and the integrity of that. And within the first 40 seconds, the dye is already left the retinal circulation and reached the kidneys and is back into the retina in the recirculation phase. Abnormal fluorescence is further divided into either a hypofluorescence or a hyperfluorescence. Hypo is, as the name suggests, where the fluorescence from either the retinal vasculature or the choroidal background flush is blocked, either due to presence of blood clots or pigments or any other lesion that is not allowing us to view the choroidal fluorescence, or the overlying clot that is blocking the normal choroidal fluorescence, or hyperfluorescence, where there is increased visibility of the choroidal fluorescence, or there is abnormal leakage from an abnormal structure. This is the basic principle. This could be either hyper can be due to leak or transmitted fluorescence or pooling or staining, and hypo can be either blocked or a filling defect. So let's go to the hyperfluorescence types. Here, this is one very classic example of a classic versus an occult CNVM. In a classic CNVM, you can see that there is a filling of the lesion in the very early phase, what we call classically described as a lacy pattern of dye filling. The entire lesion fills up during the early arterial phase itself, and the lesion borders are very indistinct and feathery, and they start to increase in size. And by the end of the fluorescein angiogram, the entire lesion lights up, and you can see the entire size of the lesion. In an occult CNVM, the filling is very patchy because the distribution of the lesion is at a different plane, and you don't see the entire extent of the lesion as typically that you would see in a classic CNVM. So this is the main striking difference that you would see in a classic versus an occult CNVM. Other type of hyperfluorescence that you would see typically in a diabetic is due to microaneurysms. This is something that we need to see. Any lesion that we are going to treat within the macula, I would always recommend a fluorescein angiogram to map out the area that we are going to treat with laser. For example, this is a large area of hard exudates, but on fluorescein angiogram, we can see that the cluster of microaneurysms and the maximum amount of leakage does not really correspond to the maximum area of hard exudates. So the leakage is somewhere else, but the extent of hard exudates is somewhere else. So probably this would guide us to doing our laser very well. So you can see these light up as small stars in the sky in the early phase, and they slowly begin to leak and become clumps over the mid and the late phases. That is how a microaneurysm would look. The other typical example of a hyperfluorescence is ink blot hyperfluorescence that we see in a CSR. That appears as a small dot of hyperfluorescence in the early phase and goes on increasing as the dye accumulates in the subretinal space, and the lesion becomes larger and larger as described like an ink blot. And by the end of the late phase, you can see a large blot. So this is a typical ink blot CSR. Here, the site of leak is the defect in the RPE, where the choroidal and the retinal circulation dye is leaking through the gaps in the RPE and accumulating in the subretinal space. So this is another example where both hyper and hypofluorescence we can see in a diabetic retinopathy, where there is a large front of neovascularization that would start leaking because there's an abnormal blood vessel and the vessels are leaky, that would start leaking the dye right from the early phase of the angiogram, and the leak only goes on increasing to become larger and brighter through the mid and late phases. And you can see that the leak is more visible in the other areas of the neovascularization also. And you can also see an area of block fluorescence where the normal choroidal fluorescence is blocked by this presence of a pre-retinal hemorrhage. And this extent of blockage, which is blocking even the normal retinal vasculature, shows us that it is a pre-retinal hemorrhage. And this is another example where there is a diffuse leakage from a capillary blood where you cannot really distinguish any microaneurysms because the entire capillary bed is leaking. This could be in a diabetic, also in a pseudophakic CME, where you see a diffuse leakage, which is showing a cystoid macular edema or a flower petaloid appearance of the leakage by the late phase of the angiogram. And the third type of hyperfluorescence that we see is a transmitted hyperfluorescence, where the choroidal hyperfluorescence becomes more visible because the overlying RPE is absent or damaged, and that allows more of the choroidal fluorescence to be seen better. So this is one example in a sick RPE due to chronic CSR. You can see more visibility of the choroidal hyperfluorescence, which is an RPE track in a CSR. And also you can see active ink blots leaks, which are active leaks from a CSR defect. The third type is transmitted fluorescence in a geographic atrophy. The main difference in the geographic atrophy and the other types of hyperfluorescence is the size and the dimension of the lesion or the patch of hyperfluorescence doesn't increase over time. It remains the same and it may fade away by the end of the late phase. So that is the main difference that we need to keep in mind. So hypofluorescence can either be blockage of the fluorescence due to blood, either could be pre-retinal or intraretinal. When the blood is pre-retinal, it blocks all the structures underneath it, blood vessels, choroidal fluorescence, everything. If it's intraretinal, the blood vessels may be visible. Filling defect, where the dye doesn't fill that area at all. So you can see that as a black patch. These are the avascular zones, and this is very necessary to plan out your laser treatment. And this is one example. How do we read a fluorescein angiogram as a postgraduate? Which eye you need to mention first, which quadrant of the angiogram are we seeing, we need to say, and what phase of the angiogram are we looking at, and what is the kind of abnormal fluorescence, whether it is a hypo or a hyperfluorescence, we need to mention, and how does it change over time? Does it increase in size, intensity, and over time, and does it fade away by the end of the late phase? And what is the likely cause of abnormal fluorescence? We may commit to a diagnosis, but it is not an absolute must. So that's it. Thank you.
Thank you very much, Dr. Srikanth. That was also again extremely good. So back to one question from me. So what are the clear indications for doing FFA in a diabetic retinopathy?
In a diabetic retinopathy, now that we are migrating more towards OCT-based treatment, especially for macular edema, and which are basing more of our diagnosis for a PDR based on fundus photos and clinical examination, there are certain situations I still do a baseline fluorescein angiogram in a patient where I can't really correlate the extent of vision loss and the extent of macular changes. In cases where the edema is very minimal, but the gross vision loss, and I suspect a macular ischemia. Or in a patient where the retina looks absolutely fine, but I can't really explain the loss of vision, could be a featureless retina. And those are the two cases where I still depend on a fluorescein angiogram as a baseline investigation to map out the extent of ischemia and also the areas of leak.
Thank you. Thank you, Dr. Srikanth. The quick thing, what Srikanth said, very nice presentation. I just want to add, before I ask Muralidhar sir to please give few comments on this topic. So whenever a question is asked on this, he has very nicely explained the interpretation of an FFA is very important. We have seen, we just conducted the postgraduate education program just 2 weeks back in Hubli, and I could see most of the postgraduates entering it as, it's a case of CSCR. So it's a case of ink blot pattern. So what I would rather suggest is first ask for the clinical findings if they give it. If no, if they give you a single frame, at least first identify whether it's a red-free, pseudofluorescence or autofluorescence, and then go in for which eye it is, whether it's a right eye or the left eye. And then you can go in for any arm retinal delay time. And then I have made a small mnemonic as SAM, sequential, anatomical, and morphological. Sequential in the sense phase by phase. I've seen many of them directly jumping into saying, sir, this is the case of DME. Which phase it is? If they give you this phase-wise, it's always better to identify phase-wise. If you get a single picture, which phase it is. Anatomical is whether it's a choroidal, subretinal, pre-retinal, and M stands for morphological. Then you can comment whether it's on hyper FAF or hyperfluorescent. Yes, Muralidhar sir, your comments and thoughts on this, please.
Yeah, thanks, Srinivas. Good presentation by Srikanth. See, when postgraduate, if in the exam, if you are given a fluorescein angiogram, as you rightly said, how to interpret it, it depends on whether you are given a single frame. Sometimes you have a large print of a single frame. In that situation, what you need to do is you have to identify the eye, whether it's right eye or left eye, whether to identify what phase of angiogram this is, and then go on to describe whatever abnormality you say. You can say, I see an area of hypofluorescence which is irregular, near the disc or near the macula, whatever anatomical description you want to give, you need to give. And the end, as you rightly said, you can give a diagnosis, or you can say, with this information, I can't arrive at a diagnosis with this single frame. If you are given a series of prints of both eyes, then you can describe this is a fluorescein angiogram, describe in the sequential event. The right eye in the early AV phase shows this, in the AV phase it shows this, and the late phase it shows this. And similarly, in the left eye, in the early phase, arterial phase, it shows this abnormality. In the arteriovenous phase, it shows this abnormality, and then in the late phase, it shows this abnormality. And that's why I think it's a leakage and not a a window defect or transmitted fluorescence. Like that, you can offer your explanation. So basically, you need to look at the angiogram and describe how you interpret it, so that the examiner knows that, okay, this fellow knows how to read an angiogram. That's all he needs to know.
Exactly.
I think it's better to, for yourself, only put it in the beginning that the minimum requirement for completing this fluorescein angiography would be a color photograph and 2 phases, one early and one late phase of the angiogram. Yes. If you're giving me only one and you don't want to give me the other, then I can only say hyper or hypo. I can't even say whether this is transmitted or increasing. So I can only comment on the fluorescein angiographic picture. I cannot comment on what comes as a functional change in terms of leak, in terms of window defect. One picture you can never comment on, and you should not also. So, I mean, this is very important because that can be a trap for you also otherwise.
Very, very valid point. Very valid. Thank you, sir. Chitra madam, we can move on to the next talk, please.
Our next speaker is Dr. Natasha Radhakrishnan, who's going to detail us on B-scan and its relevance. She's a clinical additional professor, Department of Vitreoretina Surgery from Amrita Group Hospitals. And let's hear what she says.
Good evening, everyone. Thank you, AIOS-ARC, for this opportunity. So today we are going to see how to read an ultrasound B-scan. You know that B-scan is an important adjuvant for our clinical assessment of various ocular and orbital diseases. When do we do a B-scan? We do it usually when retinal examination is not possible, either due to edema or corneal opacities, hyphema, a lot of conditions, dense cataract, where you cannot see the retina. You can also do it sometimes in visible conditions, like for tumors of the eye, ciliary body detachments, to distinguish between RRD and exudative RD, and a lot of other conditions. Now, you need to know a little bit about the physics. So before you interpret it, that is, the high frequency sound waves are transmitted from a probe into the eye. The sound waves strike the structures, and that is reflected back into the probe, converted into an electrical signal, and this is reconstructed as an image on a monitor, which can be used to make a dynamic evaluation of the eye. In ophthalmic ultrasound, we use high frequency short wavelength ultrasound that gives you higher resolution of the minute ocular and orbital structure as compared to the low frequency of an abdominal ultrasound. The B-scan probe frequency is around 10 megahertz, while we have an advanced B-scan now about 20 to 25 megahertz that will penetrate only 5 to 10 millimeters. Now, what is the image that we see? It is called an echo. It is the sound that is reflected from the interface between two media when sound travels from one media to another of different density. And the greater the density difference, the higher the reflectivity. In a B-scan, the oscillating sound beam is passing through the eye and imaging a slice of tissue. So the echoes of which are represented as a multitude of dots that come together to form an image. And the stronger the echo, the brighter the dot. Another word that you should know is gain. When gain is high, weaker signals are displayed, and when gain is low, the weaker signals will disappear. So high gain is equal to low resolution, so you will see weaker signals also. Now, this is the probe that is used, and it has a marker which will denote the position of that, and it is the marker, the area that is marked will be seen at the top part of the of the echogram. Now, there are three probe positions you should know before you interpret it: transverse, longitudinal, and axial. This is the position of the transverse scan, where it will be parallel to the limbus with the pointer either towards the superior area or towards the nasal side. And the longitudinal scan where it is perpendicular to the limbus, and it is kept with the probe marker towards the center of the cornea. It gives you the anteroposterior extent of the lesion. And you should also know about the longitudinal macular scan, in which you direct the patient's gaze temporally, place the probe on the nasal sclera with the marker oriented towards the limbus. This is a horizontal scan of the macula, and it will be seen like this. That is the probe position on top, and in the bottom is your macular scan, where the optic nerve comes in the bottom half of the scan, and the macula will be just above. Now, in a description of a lesion, you need to know the location in relation to easily demonstrable landmarks. You should tell about the extent, anteroposterior and lateral, the dimensions in case of tumors and other solid lesions, shape and configuration, whether it is point-like, membrane-like, or mass-like, internal reflectivity and surface reflectivity of the particular lesion, the structure, whether it is solid or cystic, and a degree of sound attenuation, if any. You should also include mobility, whether it which includes the movement of a live intravitreal organ or after movement such as that is seen with the PVD. Now we will look at how each one can be interpreted in detail. The artifacts that also should be recognized: reverberation artifacts occur when there is a highly reflective surface, which are often seen, especially if the amount of gel that you're using is not enough. You can also get ring down or comet tail artifacts with air bubbles or metal inside the eye. Now, how to read? So there are 3 types of echoes: dot-like echoes, membranous echoes, and tumors. The dot-like echoes, common thing that we see is asteroid hyalosis. You can see bright point echoes inside the vitreous, that is with a lucid area between the echoes and the posterior part of the eye, and that is the asteroid hyalosis with 100% reflectivity from the echoes. Now, the A scan vector at the bottom of the B scan will give you an idea about the reflectivity of the structures in comparison with the retina and sclera, which gives you the highest 100% reflectivity. So every time you should have the A scan vector also underneath, which will give you an idea about how reflective is that structure. Now, vitreous hemorrhage, fresh vitreous hemorrhage has very low reflective or echolucent, and they may need higher gain for detection. However, organized vitreous hemorrhage will give you membranes of varying reflectivity, and they are usually more denser inferiorly. So this you can see there, as compared to an asteroid hyalosis, the vitreous echoes are very low reflective, and you can see some of them are membranous in the lower half of the scans, where you can see that there are membranous echoes because of long-standing vitreous hemorrhage. In endophthalmitis, you're having inflammation in the vitreous cavity. You can get dot-like low reflective echoes, or you can get cobweb-like echoes. And sometimes thick, high reflective membrane-like echoes may be seen. And the associated features may be a choroidal detachment, retinocoroidal thickening will be marked, and sometimes scleral thickening and orbital inflammation if it has gone in for panophthalmitis. This is a endophthalmitis B scan. You can see the thick membranous echoes inside, as well as the retinocoroidal thickening, and the black arrow points to some fluid outside the sclera as well. Membrane-like echoes are the next things that you should look for. So you can get membranous echoes in posterior vitreous detachment, retinal detachment, choroidal detachment. Now, how do we differentiate these? Posterior vitreous detachment is seen as a freely mobile membranous echo, and high after movements will be seen. After movements means after the eye has stopped moving, the membrane will still be moving. That is after movements. High after movements, low reflectivity. So here you can see the PVD. You can see the corresponding A scan is extremely low reflective, and you will see after movements also. In rhegmatogenous retinal detachment, it will be a thin continuous membrane which is attached to the optic nerve. It will show 100% reflectivity, and moderate after movements if it is a fresh RRD, and no after movements if there is PVR or it is a long-standing RD. Here you can see it is much thicker than the PVD. You can see there is attachment to the optic nerve, and if you see the A scan vector, which is shown by that white arrow down, you can see that it is having a 100% spike of a retinal detachment. Traction retinal detachment seen as concave membranes with varying extent of vitreous and retinal adhesion, with minimal to no after movements will be seen. Exudative detachment, presence of a smooth bullae and shifting fluid. Sometimes you will get echoes inside because of the subretinal fluid being exudates, and you will also be able to demonstrate the changed head position. Choroidal detachment, dome-shaped elevation with a smooth surface with no after movements at all. The serous will be clear inside, and you can get kissing choroidals, and hemorrhagic will have echoes inside. Intraocular foreign body is another important thing that we use the ultrasound B scan for. It gives even better resolution than the CT, and it will be seen as echo-dense signal with shadowing persistence of signal. Posterior T sign, you can see it in the arrow there. You will be able to see fluid there. Common ocular tumors can be differentiated: melanoma, carcinoma, hemangioma. In a melanoma, you will find the collar button shape, acoustic shadowing behind, and you will see choroidal excavation. In a retinoblastoma, you will see calcification that will give you a 100% A scan spike. In an osteoma, because of the shadowing behind, you will get a double optic nerve sign. In choroidal metastasis, the inside will be homogeneously hyper-reflective. Sometimes you get rare things like ocular cysticercus. Here you can see the scolex can be demonstrated, the cyst can be demonstrated inside in an ultrasound B scan. To summarize, when interpreting a B scan, one should be aware of probe position and gain setting. A scan spike in the display should be on for additional information. The location, extent, dimensions, shape and configuration, reflectivity, mobility and sound attenuation are the characteristics to be looked at. And it's an important tool in our diagnostic armamentarium and should be used when required, and findings should be read in conjunction with clinical examination findings. Thank you all for your patient hearing.
Thank you very much, Natasha. I think you covered every possible question which could be asked to a postgraduate. Something I think which you already said, How do you differentiate an asteroid hyalosis from a vitreous hemorrhage? The postgraduate is asked. One single sentence.
Yeah, the distribution of the asteroid hyalosis will be in the center of the vitreous with a lucid zone between the vitreous and the retina. And in vitreous hemorrhage, it will be more unevenly distributed and more towards the lower part, and there will be no lucid zone. And if you pass a spike exactly through if you pass that vector exactly through the asteroid hyalosis, you will get 100% spike because of the content of the asteroid hyalosis.
Thank you, Natasha, madam. I think you have covered most of the points which the postgraduate needs to know, and you have covered the varied disease as well. So I would quickly move on to our next moderator, Dr. Guruprasad, sir. Your quick comments on the postgraduates about this B-scan and a few tips from you, please.
Yeah, I just want to add that B-scan is a very important tool. She's already told that it has to be always read in conjunction with the clinical findings. And one more thing that we need to stress upon for the postgraduate students, that it is a kinetic examination. It's not a static examination. It's not just like OCT, just like FFA, like you want to have different sections in the OCT and different phases in the FFA. You need to have movements with the B-scan should be spread over the movement of the eye, meaning you should have the mobility. She did mention mobility, but then I think it is better to use the word kinetic examination to impress upon the postgraduate students. One thing, I think there was a slip of the tongue when she said in METs it will be homogeneous. I think it is heterogeneous in the METs. The internal reflectivity in METs in a choroidal tumor, which is a MET, will usually be heterogeneous rather than homogeneous. Homogeneous, it will be more in hemangiomas with a high internal reflectivity, and sometimes pulsations can be seen. Whereas in METs, it will usually be heterogeneous because there will be different areas of different densities within the tumor with liquefaction, necrosis, and solid areas within the METs, which gives this heterogeneous appearance. That's all I wanted to add.
Thank you, sir. Thank you, Guru, sir. Jatinder, sir, quick comments, and we move on to our next presenter, Dr. Praveen Murli.
Nothing specific. Most of the things were well covered in a very nice presentation. Only thing, just to reiterate again, don't jump to a diagnosis just by seeing the scan. Just label them as the findings, as what you see, and be very clear that you mention as hyper-echogenicity and not mistakenly label them as hyper-reflective. Most people in exams, because of the stress factor, they may just jump on hyper-reflective. That's because that's a more commonly used term. So, but when you're using describing terms on ultrasound, use echo, hyper, and hypo-echogenicity rather than reflective. That's it.
Thank you very much. So we go on to our next section, how to present. And our first speaker here is Dr. Praveen Murli. He's a senior consultant, Vitreoretina and Uvea at the Kochi branch of Eye Foundation Group of Hospitals, with a great academic career, very good surgical prowess, and I'm sure he's going to do a true justice to his talk. On to you, Praveen.
Yeah, just before Praveen starts, I just want to tell all the viewers here. So this session is how to present. Basically, they're all the young Turks who are very well established in their field of vitreoretina. Now they have come up with the flying colors in their examination, and now they are the young practicing retinologists. So they'll be presenting if a case, say for example, a case of rhegmatogenous retinal detachment comes, how should be the ideal case presentation? So they'll try to give you some tips, and for further, it will be the first case will be moderated by Dr. M.S. Murlidhar sir, who will try to add on few points about what the examiner might ask and what is very important for the postgraduates to know, at least to pass in for the examination when that case is presented. Over to Dr. Praveen, please.
Thank you very much to ARC and as well as Chitra madam. So it is mainly for all the students who are preparing for the exam. Even though it's a long time since I cleared my exam, I would like to share the best possible way to give a good presentation. Most of us, before you enter the hall, we know the diagnosis either by your colleague or from the internal. And same is with the examiner. They also are not interested in you coming to the diagnosis because they also know that you know the diagnosis. However, they are more keen on how you present, whether the way you present is methodical, how you reach to a differential, whether it's in a stepwise manner, and how confident are you in presenting the case. Also, before entering, you should know your strong points and weak points so that you can insist on those points and or skip those points. So this is a 40-year-old male who presented to us with a chief complaint of sudden onset defective vision in his left eye. So the main presenting history is a defective vision, which is sudden onset of a duration of 3 days, which is progressive and is associated with floaters and flashes, which is a prior history, and it is not associated with pain and redness. So this is the main focus for us, and we can re-insist by saying that the patient has a sudden onset of defective vision and a painless thing. So when we re-insist, we are forcing the examiner to ask us the question. The most commonly they will ask, the next thing is, what is the cause of painless loss in vision? So this is how we lead them to the thing, and you should be happy that you know this answer, and you can go ahead, divide into two formats, like it can be either painless or painful. Painful can be acute congestive glaucoma, acute iridocyclitis, or painless can be in form of central retinal artery occlusion, ischemic vein occlusion, retinal detachment, or massive hemorrhage. If you want them to lead again to further question, you can even tell or repeat the thing that preceding to the symptoms of defective vision, there was some brown particles, certain floaters, which was associated with flashes of light prior to the defective vision. So the next question they may ask is, what is the cause of flashes or floaters of light? So you can, again, instead of directly going to the answer, you can just tell a little bit about floaters, whether it was black or gray dots, whether there were lines, red light, cobwebs, rings. And this all can depict what is the condition in the eye. Like if it is a dark brown or black with lot of showers, it can be like a sudden blood in the vitreous or in the AC. It can be PVD induced. Or flashes you can get either in PVD or migraine, etc. Again, further going to the history, ask for any similar episode in the same eye or the other eye. If the patient had any trauma, there was no history of any redness, pain, watering, exposure to bright light, UV light, sunlight, no travel history, or no other relevant histories. Coming, the next part is about the past history. So you can ask again for a similar episode in the same eye or the other eye, or whether the patient had any procedure or any surgical. The third thing is about the personal history. Go ahead and ask for any systemic illness or any medication also. Family history also similar episode or history of similar illness. Post the history, I'll skip the systemic examination where you have to take about the RS, CVS, all the other part, but I'll directly go into the ocular examination. So we go always in a stepwise order. First you say about the visual acuity or the best corrected visual acuity, right eye, left eye separately, the intraocular pressure, right eye, left eye. When you come to intraocular pressure, you have to mention whether it's Schwartz or applanation. Then go ahead with the eyebrow, look for any signs of trauma, if there are any positive signs.
1 minute left.
I request Dr. Praveen, you can move on to the findings directly.
So when it comes to finding, go ahead. When you are presenting, you have to tell in form of fundus examination. Fundus examination, you have to tell whether you are doing it a direct ophthalmoscope, SITLAM 90D, or indirect 20D. Direct ophthalmoscope, you have to again mention in form of you are looking at distant direct ophthalmoscopy, where in the whether you have seen a good glow or a dull glow. So dull glow itself suggests that whether the cataractus is there or whether some pathology is there in the retina. Coming to the fundus picture itself, when you are saying, first say of the normal eye, as a PG, you always have to say that the media is clear. Then you describe the disc. Disc is of normal shape, size.
Go ahead, Dr. Praveen, please.
Yeah, and then of the pathological eye, you can say what is the extent of the detachment, whether it's nasal, inferior, superior. see the amount of detachment, say the clock hours involved, how was the surface, and see the patient both in sitting and lying down position to see for any change in fluid level. And the last is, after all this, you describe what is the differential or go ahead with the diagnosis. Diagnosis, like this patient was left acute subtotal legmotogenous retinal detachment involving the infranasal, supranasal, supratemporal quadrant with macula on or off.
Done, Praveen?
Yeah.
Yeah. Okay.
Okay. Thank you so much, Dr. Praveen. Though it was a very short time, I apologize for that because we had to discuss a little bit more about many of the other cases as well. So I think I would like Dr. N.S. Muralidhar sir and Dr. Praveen to please moderate this case presentation.
Yeah, I think Praveen covered very well many points in the history regarding the onset, the history of flashes, floaters. Some more things I would say when I am presenting a case of retinal detachment. I would say that I have asked for ocular history, whether patient was wearing glasses, whether the patient is a high myope. This is something we have to ask the patient, whether the patient has history of ocular surgery or a YAG capsulotomy in the recent past. This is something we can say. I have asked and the patient does not give a history of this. Then history of trauma, either a major trauma or even a trivial trauma. We all know that patients with high myopia, even with a trivial trauma, can develop a retinal detachment. And important thing is, what was the vision of the patient before the onset of detachment? Because often we see unilateral high myopes with amblyopia developing a retinal detachment. So it's important to document that the patient's vision was good or not good before he developed the retinal detachment. These are some of the points which you might want to tell the examiner, that, okay, patient had good vision in the eye. He has history of no history of wearing glasses in the past. He enjoyed good vision, no history of ocular surgery, no history of trivial trauma, no history of YAG capsular, like these, some of the points. And family history of retinal detachment is an important negative thing that you have to elicit from the patient. Past history of myopia, trauma, ocular surgery, that I think we have covered. So when it comes to the retinal detachment description, you have to describe the extent of retinal detachment, total, subtotal, involving 3 quadrants, 2 quadrants. And most important is presence of tears, retinal breaks. Retinal breaks, you should describe what is the meridian of the break, what is the type of break, whether it's a horseshoe tear, and whether it is, what is the size of the break? It is a small horseshoe tear or a big horseshoe tear or a large hole or a small hole, in which meridian, whether it's in the equatorial region or anterior to equator or posterior to equator. And what are the number of breaks, whether additional pathologies present like lattice degeneration. These are some of the things, and presence of other associated things like PVR, presence of star folds, presence of subretinal bands. And if there is PVR, you should be able to grade the PVR at least according to the earlier Retina Society terminology. You may not be expected to grade the RD according to the latest silicon study terminology or something like that. At least the earlier terminology of A, B, C, D, C1, C2, C3, and D1, D2, D3. At least that much knowledge the candidate should be able to tell, should be able to exhibit. So I think I have finished my comments. Yeah.
I'd like to say
only one more point I would like to ask is pseudophakic eye. Then you must examine the anterior segment and comment on the status of posterior capsule, whether the posterior capsule is intact or broken, whether the IOL is stable, well-centered or decentered, because during surgery, this all may pose a lot of problems.
Thank you,
I'd like to point.
Yes, Dinesh.
Yeah, see, when you talk about sudden vision loss, you have to differentiate that from sudden detection. Sudden detection is that he closed the other eye and found he couldn't see from the other eye. Sudden deterioration means that you were seeing with both eyes. Till yesterday you saw you were seeing, and suddenly you see in front of you the vision in one eye starts dropping. The two are very different. Sudden detection occurs in amblyopic eyes. So you have that, or a pre-existing eye, an eye with a pre-existing low vision. So it's an indicator of prognosis. So it's very important to make this differentiation. The second thing is, For a rhegmatogenous detachment, the detachment has to come up to the ora. So when you say that, when you're trying to make your diagnosis, you will have to say that this retinal detachment came up to the ora. If it did not come up to the ora, it is a tractional detachment. So that is another point. The other thing, because the features which will differentiate a tractional detachment or an exudative detachment from a rhegmatogenous detachment have to be said in your examination. So for example, when you say that the surface of the retina was corrugated, it was not smooth bullous. When you say smooth bullous, it signifies you're thinking in terms of a exudative detachment. When you say corrugated, then you're talking in terms of stage B, rhegmatogenous detachment. So that differentiation has to come. And of course, based on the location of the detachment, then you have to point out whether with Linkoff's rules, or if you couldn't find the breaks, by Linkoff's rules, are the breaks going to be there only? Or if you found the breaks, do the Linkoff rules and the position of the break explain the detachment? These points must be brought out when you talk about your case.
Thank you.
Excellent job. Don't forget the other eye. Don't forget the other eye.
Yeah, true. Thank you. Thank you, Dr. Praveen. All the postgraduates, I think, here need to understand that what we have in this panel, that is the how to present, like Dr. Praveen, who is a senior consultant, we try to bring down to your level and try to make the presentation, try to make the best out of you. We are all putting in efforts. I really appreciate Dr. Praveen to though he has passed the exams long back, but again, we had to come back to the what are the how's the ideal way to present and all these things. I really appreciate your efforts, Dr. Praveen. Thank you so much for volunteering. Over to Dr. Chitra, madam, for the next presenter.
I think next presenter should be
we have Dr. Divakant had some issues in the family. He had attend some urgent things in the family. So we have Dr. Madan Joshi here, who is the registrar at MM Joshi Eye Institute, who is a young, sincere, dynamic, though a little bit introvert, but very soon is going to be a prolific vitreoretinal surgeon in Bellary. Over to Dr. Madan, please.
And,
I request Dr. Dinesh Talwar sir to please moderate this case.
And even before he presents, we need to appreciate the fact that he was given a half an hour notice to present his talk. So let's hear from him.
Yeah, thank you, ma'am. Thank you, sir. So I'll be presenting a case of a 54-year-old gentleman who came with complaints of decreased vision in the left eye since 3 weeks, which was gradual and painless. And he also complains of decreased vision in the right eye, which was gradual, but it was less significant than the left. He was using reading glasses since 10 years, and there was no history of pain or redness or no history of flashes or floaters. He's a known case of diabetes since 12 years on oral hypoglycemics. Attender tells that the diabetes is not under control for last 2-3 years. And there is no history of any surgeries or any other systemic illness in the past, or no history of any eye treatment in the past. So both mother and father are known case of diabetes. Personal history is normal. There are no habits. So moderately built and nourished with stable vitals, and systemic examinations are within normal limits. So coming to ocular examination, the right eye, best corrected visual acuity is 6/12, N8 with plus 2.75, and lids and adenoids are within normal limits. I want to highlight few things for the postgraduates here. If you are presenting a case of diabetic retinopathy or any posterior segment case, you need to focus mainly on more on neovascularization and RAPD and intraocular pressure and vision. These 4 things you should never forget, and even gonio if you're presenting a case of diabetes. So anterior segment findings were within normal limits in this patient with normal intraocular pressures, and left eye best corrected visual acuity was 1/36, and anterior segment findings were within normal limits. So coming to fundus examination, this is a fundus examination of the right eye. Media is clear. Disc is CDR ratio is 0.6 to 0.7 with healthy NRR. AVR ratio is 2:3. And coming to background changes, there is neovascularization of the disc. It's almost extending from 6 to, you can see here, from 6 to almost 2 clock hours. And the neovascularization of the disc, and around 1 disc diameter away from infero nasal to the vessel, you can see a neovascularization with fibrovascular proliferation around 1 disc diameter in the sides, with background dot blot hemorrhages in all the quadrants, and flame-shaped hemorrhages along the inferotemporal arcade. And I am sorry for the bad picture, but there is a macular edema with hard exudates. So coming to the left eye examination, this is a media is clear and the disc can be faintly seen. The disc appears perfused, and there is extensive fibrovascular proliferation along the in the posterior pole, and you can see here neovascularization and a few collaterals in the superiotemporal part of the fundus. And there is in the periphery, inferiorly, there is vitreous hemorrhage. Here mainly for the postgraduates, you should be well versed with the diagrams, and the color coding is very important if you are presenting a case of diabetic retinopathy. So you must be well versed with the color coding. So coming to diagnosis, right eye SIMC with proliferative diabetic retinopathy with macular edema, and left eye NS2 cortical with proliferative diabetic retinopathy with TRD with vitreous hemorrhage. Thank you.
Thank you, Dr. Madan, for preparing in just a half an hour's time, as Chitra Madam said. Over to, where is Dinesh sir?
Yeah, hi.
Yeah, he's here.
Thank
Yes,
you very
Dinesh
much.
sir.
I think you've done a great job
Sir,
for
you're muted.
the time.
Sorry,
That,
I'm muted.
am I muted?
No, I had kept it. Go ahead.
Yeah. So for the short duration that you've been given, you've done a great job of giving us the essential seeds of what we need for a presentation. As mentioned, the most important thing is that you must not miss about relative afferent pupillary defect. So therefore, your first examination has to be before dilation, and then only the dilation is done. The second thing is that you have to look for neovascularization, and then that is not just neovascularization of the iris, which is not just at the pupil, but also at the angle. So both have to be looked at. So gonioscopy is an essential part of this examination, especially the kind of case you presented where one eye vision was less, significantly less. But before you come to that, all cases won't be such severe ones. So when you talk about the history, it's very important to go a little more into the history. See, in diabetics, what you get is macular edema as the commonest thing, and then PDR as the second thing. So what would the patient come with? Not just blurring of vision. The second thing would be micropsia. So you must know whether there's a history of micropsia, and you must note it down. The second thing is a history of floaters, because that's the key to you, that this patient may have gone up to the stage of proliferative diabetic retinopathy. So, so this is the other important thing. The third thing is whether this has been a constant thing or there's been fluctuation. Fluctuation is likely to happen with the vitreous hemorrhage. A constant slow decrease is likely to happen with a diabetic macular edema. The last thing is about near vision. If the patient says his near vision has been going, this is preferentially a sign of a macular disorder. So that's another sign that tells you that there's something wrong. Your vision must be both. You're not going to do a pinhole vision only. If you get a pinhole vision, you must also do a BCVA in your patient, because pinhole vision in macular disorders is less as compared to the unaided vision. So this is the other important thing. As far as the history is concerned, you also need to check for hypertension, nephropathy, cardiac disease, drug allergies, because you may be doing a fluorescein angiography for this patient. Bronchial asthma. These are some of the things which I would do as a routine to make sure we don't miss this when we go ahead for investigation of the patient. The next thing is extraocular muscles. Patients with diabetes, it's not just a diabetic retinopathy, he could also get a sixth nerve palsy. So you must also check out for the extraocular muscle movements, and so that you don't miss that. When you come to the fundus, the cup must be looked at. Diabetics are also more prone to glaucoma. So in the process of looking at diabetic retinopathy, should not forget about glaucoma. So this is one part. The second thing is, now when you come to the changes, The important thing is you're looking clinically and you have to differentiate this clinical examination. Does this patient need, for example, a fluorescein angiography? So now, if the patient has severe or very severe NPDR, how will you diagnose that? So you have to see, does he have microaneurysms or retinal hemorrhages in all 4 quadrants at the posterior pole? One sign. Whether he has venous beading, easily found. Whether he has irmas, difficult sometimes to pick up, but look carefully for tortuous vessels which seem to sort of form a cluster. The vessels per se being very fine, less than 31 micron in diameter. These are the signs that tell you you're dealing with severe and very severe NPDR. Patients who need to be taken up for, you may want to take a fluorescein angiography so that you don't miss an early PDR in these patients. So this is the other important thing. So these are some of the things which we need to do before we come to a final diagnosis. Of course, if you have severe fibrovascular proliferation, as you had in this case, so it's clear cut, there's not much of a problem. The problem comes in severe NPDRs with macular edema. There, your description has to be complete, so you don't miss something. I think that that's just to add to whatever you talked about, the more severe varieties of proliferative diabetic retinopathy.
In connect with what you are talking, Dr. Dinesh, even if it's an asymmetric diabetic retinopathy, as it probably was in this case, you should also think of some cardiac and carotid disorders also.
Exactly. So if you, this is the other thing, that's very good point. If you see asymmetry between the 2 eyes, then you have to look for the cause. So the cause could be the patient's hypertensive. That could be one. The patient may have pseudophakia in one eye. That eye could have a more severe disease process. So these are the things which need to be looked at also. Also, if the flame-shaped hemorrhages are more and dot hemorrhages are less, then this is more of a component of hypertensive retinopathy. This is not diabetic retinopathy. So that means the combined picture has more of an element of hypertensive retinopathy within it. So these are some of the other things too.
Mixed retinopathy is what we usually mention it as. Thank you, sir. Thank you for that point. And usually asymmetric retinopathy, when we also do it, when the patient is not having DR changes, but having DR changes in other eye, in those cases, we usually have to rule out OIS as well. We have to do a carotid Doppler in these cases to rule out what's the stenosis of the carotid arteries. I think we'll come to the end of that and we'll go on to the next speaker. Yes, over to Chitra madam, please. Thank you, Dinesh sir. Thank you, Dr. Madan. Wonderful case.
Yeah, wonderful case and wonderfully discussed. Our next speaker is Dr. Giriraj Vibhuti, who's a consultant vitreoretina at the prestigious M.M. Joshi Eye Institute, besides being a visiting consultant to various cities with multiple national and international awards for his surgical videos. Let's hear from you, Dr. Giriraj.
Thank you. Thank you to Dr. Srinivas sir and Chitra ma'am and team ARC for this opportunity. Okay, I'll try to finish within the time given to me. Let's start with the case. This Mr. AB, who presented to us, who is a 65-year-old gentleman, a shopkeeper from Hubli, who presented to us with complaints of diminution of vision, which he noticed since last 1 month. According to him, he was apparently normal till 1 month when he developed diminution of vision in his left eye, which he noticed suddenly, and it was painless, progressed over last month, and it worsened since last 1 week. Patient hasn't consulted any doctor prior to this. He didn't have any similar complaints in the past. There is no similar complaint in his other eye, no history of trauma or no history of using thick glasses. As we are presenting a retina case, the history of thick glasses becomes more important. No history of flashes or floaters, no history of headache, and no history of COVID-related illness. This has become important in current times. Patient is recently diagnosed hypertensive. He was started on antihypertensives just 15 days before. He is not a diabetic, not on any prolonged medications. Personal history, sleep, appetite is normal, bowel and bladder habits are regular, no addictions, and family history is not significant. General examination was normally was moderately built and nourished, well oriented. Pulse was 82 beats per minute, regular and rhythmic. His BP, as he is recently diagnosed hypertensive, still it was 170 by 90 millimeters of mercury in sitting position. No pickle, and systemic examination was normal. Coming to ocular examination, starting with head posture, facial symmetry, and ocular movements, they were fully normal. And conventionally, I'll mention the right eye findings first. His uncorrected visual acuity was 6 by 36, which was improving till 6 by 12 with refractive correction. Adnexa, conjunctiva, cornea were normal. Iris was normal. Coming to the important features of the left eye, his visual acuity was 2 by 36, which was not improving. Cornea, adnexa, conjunctiva were normal. Again, I want to concentrate on iris. There was no NVI. It was normal in pattern. Pupil was round, regular, and there was no RAPD in this case. Lens showed nuclear sclerosis, grade 2 cataract. Anterior vitreous phase was normal. GAT, again important finding, measured at 2 p.m. It was 16 millimeters of mercury. So conventionally, the right eye, even though it appeared normal, we should look at the vessels also. Vessels showed a few AV nicking signs, which were suggestive of grade 2 hypertensive retinopathy. And coming to the eye proper, the examination eye proper, in the left eye, the media was clear. Optic disc was normal in size, shape, color, pattern, and the neuroretinal rim was healthy. The margins were well made out. As we can see in the diagram, there were multiple superficial and deep hemorrhages which were straddling along the superior temporal arcade. Mainly, they were mainly inside the arcade, but few hemorrhages were outside the arcade also, and few were in the macular area also. On the 90D slit lamp biomicroscopic examination, we could see the foveal elevations and without any foveal reflex, suggestive of macular edema. So this is the fundus picture of that patient, and we can see venous dilatation also. So coming to diagnosis proper, my diagnosis is left eye superiotemporal branch retinal vein occlusion with macular edema with grade 2 hypertensive retinopathy and the incidental finding of nuclear sclerosis grade 2 cataract. Right eye had nuclear sclerosis grade 2 cataract with grade 2 hypertensive retinopathy. Thank you.
Nice presentation, very nice.
Thank you, Dr. Giriraj, for quickly presenting a case of BRVO. I now request Dr. Lalit Verma, sir, to please moderate the case.
Excellent, Vibhuti. You have just presented like a resident, although you are a consultant, I know. That's the beauty of your presentation. I would not be able to add much, but except that, once I'm talking of hemorrhages, I may tell that it's predominantly superficial hemorrhages and the numbers also, because sometimes the number of hemorrhages may give a clue to the ischemic process going on. And I would also mention there are no soft exudates there because soft exudate again will reflect ischemia. And I would also say the horizontal raphe is respected. Because sometimes this, even though it may be a branch vascular block, sometimes it may have a component of hemispheric block also. You rightly emphasized IOP and rubeosis and other things. That was very nicely done. AV changes also, like right eye you said has some hypertensive retinopathy. History-wise, I think something more needs to be maybe deciphered, because if we are talking only of ocular condition or some systemic conditions, because we also need to remember that a lot of these vascular blocks may have a hidden cardiac issues or systemic issues also. So those also sometimes we have to decipher and add. And also, if somebody, some JR junior is presenting history of any investigations done in the past or treatment history, because a lot of people nowadays jump to injections as soon as they see any macular pathology or any vascular pathology in the eye. So we do, sometimes you can tailor the examiner to ask questions into anti-VEGF of this also. So like he hasn't received any injection in the past, or a lot of these vascular blocks, specifically BRVOs and small vascular blocks, may be just an incidental finding, which may be detected only on closure of one eye if they are not hampering vision too much. Otherwise, excellent job done, and from the residency point of view. But investigations are very important, because one vascular event in the eye means vascular event in the body has to be ruled out. which may be cardiac. You have to somebody has to tell some cerebrovascular. Some people have to tell it does not have any history of this, so that examiner knows that you are aware that vascular event in the eye means it could have correlation with the autoimmune disease, brain disease, or giant cell arteritis. Sometimes over the age of 50, 60, people may, although more commonly as central CRVO, but sometimes any vascular block can present. So sometimes BRVO can convert to CRVO also.
Thank you, Lalit sir, for nicely spelling out a few more points which the examiner or might ask and the student have to answer. Jatinder Singh, we have 1 more minute. You want to add?
I think all the cases which have been presented, I mean, BRVO and diabetic retinopathy especially, one important history that is there is, as Dr. Verma said, about this history of taking injections. So the history that should be history of any treatment should be in significant detail. That is the number of injections taken, the time gap between the injections given in each eye, if it is given bilaterally, and following the injection, was there any improvement or not, time since the last injection, and probably a clue to what injection has been used. Even just the cost, sometimes the patient doesn't know the name of the injection. Just the cost of the injection, though it's quite variable based on different cities, that itself can give a clue to what injection has been used and whether it was changed to give an indication whether the treatment the patient condition was responding to treatment or not. The non-responsive edema, again, you need to look out into other history, that is uncontrolled hypertension, nephropathy, as sir has already mentioned. In addition, history of using glitazones, thiazolidinediones, drug history, that also should be probed into. And I think more important is to recognize whether the patient's condition is just a usual, easily treatable kind of condition or a difficult case scenario that has to be brought out from the history, and then later on from the corroborated with the examination.
Any history of laser done, because BRVOs normally a lot of people, after a couple of injections add laser also just to minimize the number of injections. What I was trying to say is you can tailor your description or verbal whatever you are presenting so as to tell the examiner that you have asked investigations, treatment, any angiograms he's carrying, or they are carrying some pictures of OCT. That will make the job easier. So otherwise, wonderful job done, Giraj. Congratulations.
I just want to add a point about the COVID history that he took.
Yes.
We have had several cases of COVID fever in the past coming with vein occlusions, sometimes arterial occlusions, and frank vitreous hemorrhage also. And I think we have seen close to 10 to 12 patients now. I think it's important and relevant in the present scenario to take a history of COVID fever in all these venous occlusions. Yes. Or arterial occlusions.
Rightly pointed out. Thank you, sir.
Thank you.
And one more point, Dr. Joshi, can I highlight one more point? I think that description, whether the hemorrhages are respecting a particular quadrant has to be emphasized. If the hemorrhages are not limited to a particular quadrant or a particular geographical location, horizontal raphe, then the history of other things, I mean, even a patient with young branch vein occlusion, you have to look into other history also. Branch retinal artery occlusion can be associated with Susac syndrome, and those kind of things also may need to be probed into that.
Thank you. Thank you, sir.
That was a very good discussion. So we go on to our next speaker, Dr. Vishal Govindari, who's a consultant vitreoretina and uvea services at LVPI Bhubaneswar, with his area of main clinical interest in diseases of macula, myopia, and newer imaging modalities. He would be discussing a case of retinitis pigmentosa. On to you, doctor.
Yeah, thank you, Vishal. I think now he is the consultant at Pushpagiri Vitreoretina Institute at Hyderabad. Over to Dr. Vishal.
I'm so sorry.
Thank you, Chitra.
I should have asked you.
Thank you, Srinivas sir, for the opportunity. Instead of a routine case, I just wanted to highlight the important checkpoints at a given case presentation of retinitis pigmentosa. Considering
your voice is very feeble. I don't know if I am hearing that.
Now? Can you hear me now?
No, little more louder, please.
Can you hear me now?
Much better.
Much better now.
Yeah. So I would just be looking at the important checkpoints during the case presentation as opposed to presenting a case, because I had discussed with Srinivas sir and he had given me the freedom of discussing what is important. So considering 5 minutes, here is what I have to present. With respect to demographics and retinitis pigmentosa, what is very important with respect to age is the majority present between the 2nd to 3rd decade. And the inheritance patterns actually influence the age of onset, while Leber's is a juvenile variant. And with respect to gender, you have the X-linked recessive affecting predominantly males. Presenting symptoms invariably include first being night blindness, followed by poor vision, eye ache, and deafness. Visual impairment is more severe in the X-linked recessive variant rather than autosomal recessive compared to autosomal dominant. Photophobia appears later in the clinical spectrum. Contrast sensitivity gets affected, and dyschromatopsia also gets affected in case of macular involvement. History of present illness is important because it's a very insidious onset invariably. It has a very gradual progression. Specific complaints with respect to dim light or night activities in early stages. Difficulty in driving or activities dependent on visual fields, and no diurnal variation impairment as age progresses. Family history is very key. The involved family member, whether parent, sibling, uncle, aunt, or grandparent, and the importance of parental consanguinity, as you can see the degrees according to the National Health Scheme of the UK. The mode of inheritance on the right gives you the simplex, that is the sporadic variant, versus the percentages of different kinds of inheritance. Pedigree charting, which is expected in an RP case. Just to simplify it, dominance versus recessive, there's always a skip noted in recessive. Autosomal versus sex-linked, father to son transmission happens only in autosomal. Y-linked, only males are affected. Mitochondrial disorders, mothers alone transmit the phenotype. X-linked dominant, fathers do not transmit to sons, and X-linked recessive, males are more commonly affected. So this is just a quick representation on how to show the pedigree charting. And this is how dominant, where there is no skip. In recessive, there is a skip. X-linked dominant, where fathers don't transmit to sons, and the X-linked recessive, where males are predominantly involved. Smoking and alcoholism are known to worsen, especially smoking, and a combination can lead to lung cancers in case of vitamin A therapy. Systemic history is extremely important considering syndromic associations, ushers with deafness, and Bardet beetle presenting with the obesity, psychomotor delay, hypogenitalia, renal abnormalities, and neurogenitary changes. There are a whole host of other diseases like Alport's, cocaine's, A-beta lipoproteinemia, mucopolysaccharidosis. These are quite academic, but at least knowing one sign like Alport's nephritis, A-beta lipoproteinemia having steatorrhea, and BTs having corneal crystals are something which is expected. These are the mitochondrial deficiencies, which disorders which are associated with pigmentary retinopathies. Kearns-Sayre, NARP, and MELAS are the 3 things which are essential. There are a whole host of other associations which are for us to remember if required. This is the picture with Bardet beetle where you have polydactyly and hypogenitalia, while this is a patient with ushers. In case of visual assessment, you do uncorrected and best corrected. Color vision gets important in case of optic nerve involvement, and the low contrast visual acuity to assess the macular involvement. Nystagmus in case of LCA, RAPD as discussed can occur also in LCA. Extraocular movements in case of mitochondrial involvement, and a thorough slit lamp examination. You have these ocular associations like keratoconus, posterior subcapsular cataracts, and disc drusen. With the fundus, you have the early stage having, apparently featureless retina. Over time, you can see the atrophy coming in, the retinal atrophy with the macula being spared, and in the final stage having all the 3 symptoms of waxy disc, attenuated vessels, and bony spicules. CME, cystoid macular edema, epiretinal membranes, and traction are a common association. A differential diagnosis of gyrate, choroideremia, or cone rod dystrophy have to be mentioned. Some infectious pigmentary causes also form the differential like syphilis and DUSN. There are some atypical variants like albipunctatus and the sign pigmento or the sectoral RP, which also have to be known when you are giving your final diagnosis. Among the investigations, unless and until you have a diagnostic dilemma, ERG can pick it up, but if you already have a diagnosis, it's not needed. As shown, early phases where the fundus doesn't show much is the ERG which gives you the diagnosis, but with progression, the photopic response also gets affected. As you can see, the HVF initial scotomas around the 20 degrees, which start to close in on the tunnel, which constricts over time. OCT is being used nowadays to assess cystoid macular edema, to understand traction, and to assess foveal atrophy. Dark adaptometry and EOG are seldom used. Autofluorescence is one thing which I would add to understand the progression over years with the Robson's ring, and a multifocal ERG in case of vision not explained by the grade of atrophy. Genetic analysis becomes key to identify the particular mutation and the risk of transmission to offspring, to understand the clinical cause and whether they're eligible for gene therapy or not with respect to availability of therapy. There are a whole host of genes involved with the is the most common one. I'll just take a minute. The final diagnosis should ideally be mentioned a rod cone dystrophy rather than RP. Likely to be RP is a better way to put it. Mentioning the atypical variants and systemic associations in the final diagnosis is essential. Quick treatment view is just to assess for cataracts, macular edema, and providing low vision aids. Vitamin A has been tried along with docosahexaenoic acid, but of limited value. Gene therapy, photoreceptor cell death therapy, and retinal implants are the way to go with respect to what is expected as future prospects with retinitis pigmentosa. Thank you.
Very good presentation.
Thank you, Dr. Vishal. I think you gave an overall glimpse, but I would like to ask Dr. Guruprasad sir, whenever this question comes, a case comes to the postgraduate, what are the must things that he has to answer and he has to know for him to just pass out this?
Yeah, I think you should not have given him the liberty of presenting it differently. He has taken away my job.
He has mentioned it as liberty, so he has taken it. No worries. Go ahead.
So yeah, I'll probably restrict myself to what the questions might be asked. I think they might ask, what are the causes of night blind? What are the causes of night blindness? So I think candidates should be very familiar with what are the causes of night blindness, like vitamin A deficiency, myopia, glaucoma, cataract, cirrhosis, and all those things. Then the question will come whether is dealing with a primary pigmented degeneration or a secondary pigmented degeneration. So I think age comes to the rescue. If the patient is young, then probably it's a secondary one. Primary is usually the ones which are inherited either sporadically, either sporadic or inherited autosomal dominantly or recessively or X-linked, and therefore because the sporadic ones are the most common, probably the primary ones are the most sporadic ones. If it is elderly, then probably the differential diagnosis of paraneoplastic disease will probably come, ophthalmic artery occlusion. And other thing, he already mentioned the differential diagnosis of diffuse uveitis, syphilis, paraneoplastic syndromes. I think that, I don't know whether he mentioned that, scar and mar can present in the elderly as a sudden onset of night blindness and loss of vision. Did you mention that, Dr. Govindhari?
I did not mention that.
Okay, so that is one differential diagnosis. Drug toxicity is another thing. Cirrhosis is one thing that can masquerade as retinitis pigmentosa, spontaneously reattached retinal detachment, and DUSN. I think these are the things which can be listed in the differential diagnosis of retinitis pigmentosa. ERG, I think it's important to know what the ERG findings are in a patient with retinitis pigmentosa, and it's important to know that even carriers can have B wave delay. And the variants you already told, the sectoral ones involving 1 or 2 quadrants, central RP, pericentral RP, unilateral RP, all these things are some things, certain things that should be known by the candidate. I think the other things you have mentioned very well, the syndromic associations, the secondary ones. Basically what primary means is that retinitis pigmentosa, which is not associated with any systemic illness or systemic syndrome, and second is the one which is associated with the syndromic associations. Bardet beetle, which is like he listed out very well, at least one characteristic of each of these syndromic associations one should know. I think he has done a very good job in presenting the case and also telling about what is important in the presentation, what one should know. I think there's not much for me to add to what Dr. Govindhari already has told. Yeah.
Thank you, Guruprasad sir, for that viewpoints, which I think the postgraduate must know to pass in any case given as retinitis pigmentosa. And overall view has been given very nicely by Vishal. Thank you, Vishal. Thank you, Guru sir. We'll go ahead with the next talk.
Dr. Srinivas, can I just make a quick
please,
point here?
Please.
I think the whole objective of this session it was quite clear, but I have a small disagreement that it should be just to pass exams. I think the main focus should be how would you approach a case when you are sitting alone in an OPD without any help. That is how, if you see picture yourself in that situation as a postgraduate and you prepare for that situation, you will not only pass exams with flying colors, but you will also become a good clinician. So just for any case presentation, not just these four, but any case presentation, I think your history should include the features that you are probably ending up, the diagnosis which you are ending up with, that is to establish the diagnosis, the factors that you are going to establish the diagnosis, then the factors that are going to give you a differential diagnosis, and also to include the atypical features of a disease that you are actually going to discuss in the end. The examination should be comprehensive, starting from anterior to posterior, not excluding extraocular movements or adnexa or anything. That is mainly to look for any comorbidities that one disease may have. A diabetic patient may have sixth-nerve palsy, as Dr. Talwar had already mentioned. So just not to exclude any or miss out any comorbidities, but also to include or pick up diseases which are coexistent with the disease that is being presented. So you may have one case with multiple factors or multiple disease, like a diabetes with glaucoma or diabetes with any other coexistent problem. And the end, if you reach the diagnosis, you have already passed most of the cases, I mean, which I have come across. If you have reached the diagnosis without much of like flumming around, so you have already passed exam, then you have to just propose the differential diagnosis, and whenever possible put a differential diagnosis, unless it is very clear-cut discrete diagnosis like retinal detachment, give a differential diagnosis whenever possible. So once you reach that stage, then it is all theory, and whatever is your knowledge you have read through, it will take you through. That's it.
Yes, and one freaky examiner can even ask you what is treatable retinitis pigmentosa, and you should have an answer for that too. So we go on to our next speaker, who is none other than our eminent Dr. Srinivas Joshi, and he is going to detail us on anti-VEGF as they stand today. On to you, Dr. Srinivas.
Yes, madam. Are you seeing it in a slide share mode? No.
No.
One second. I'm sorry for this.
You have to go on the slideshow now. We are seeing the
1 second.
screen.
Yeah. It's not taking up the slide share.
So first, just open the presentation, then do the share.
There's a dual screen here, which is probably not allowed. Well, anyway, we'll go on with the next Piyush talk, madam, and then I'll come back to mine.
Just a minute. So our next speaker is Dr. Piyush Bansal. Of course, Srinivas will take on again, who's going to be delving into lasers in retina. And Dr. Piyush is the founder director of Bansal Vision Institute at Pune, a very dynamic vitreoretina consultant with an amazing presence and a great future. So on to you, Dr. Piyush.
Good evening, madam. Thank you. Are my slides visible?
Yeah, you have to be louder.
Are my slides visible?
Yes, sir. Can you just speak a little louder, sir? Slides are visible.
It's very clearly visible, and you're very nicely audible as well. Go ahead, Piyush.
Just give me a minute, because there's some problem over here as well.
I checked earlier, actually. I don't know why. Yes.
Okay, so good evening, everyone. I'll be talking about lasers in retina. First of all, I would like to extend my gratitude to Dr. Srinivas and Dr. Chitra Ramamurthy for extending the kind invitation to me to be a part of this wonderful update, wherein I have been given an opportunity to brush up with a lot of my basics as well. It's been a very long time. So to begin with the presentation, briefly delving into the history of lasers, the description of the first instance of retinal photocoagulation, albeit not with laser, dates back to 400 BC, when Socrates first described burns of the retina during a solar eclipse. Later on, German ophthalmologist Mayer Schickerwath developed the first solar photocoagulator using a carbon arc light source. Now, as we all know that laser is the acronym for light amplification by stimulated emission of radiation. Laser has some special properties, some of them being that it is nearly monochromatic. Monochromatic means that it is of single wavelength or one color of light. Laser radiation is highly directional, and it is produced by a beam that is spatially narrow and has low divergence relative to other light sources, and it is highly coherent. That means every beam is thought to be in phase with another at every point. Now, briefly talking about the laser system and media, it basically has three components: the pumping system, the optical cavity, and the lasing medium. The pumping system provides the energy to the atoms of the lasing medium. This excites the atoms from a state of low energy to a high energy state. This results in amplification of the number of photons and produces the laser. The source of laser for the pumping system could be of different types, could be flash lamps, laser, electrical discharge, or chemical reactions. Another important part is the presence of a mirror on either sides of the optical cavity. The mirror on one side is 100% reflective, whereas the mirror on the opposite side is generally 90-95% reflective. This allows for the beam of photons to pass through it as laser, and the remaining is reflected back. Now, a laser tissue interaction can be of different types. The first being photothermal. Now, this includes photocoagulation. Now, what it does is there is an absorption of light by the target tissue, which causes a rise in temperature and a resulting denaturation of proteins. Typically, the argon, krypton, or diode frequency doubled Nd:YAG lasers cause this type of effect. The next one would be photoionizing, which includes photo disruption, essentially the 106 nanometer wavelength range. So this high energy light is deposited onto the target tissue, and this causes an acoustic shock wave. This disrupts the treated tissue. Essentially, the use in retina is most of a hyalotony. The Nd:YAG laser works via this mechanism. Now, the argon blue is a gas laser. The double frequency Nd:YAG laser is a solid state laser. Diode or red laser is a semiconductor laser, and we have the yellow laser, which is a 577 nanometer laser. Briefly going into the ones that are commonly used, the argon blue-green laser, the wavelength is in the blue-green spectrum. It's absorbed selectively at the RP, hemoglobin, choriocapillaries in the inner and outer retina level. The main adverse effects, however, over here are high intraocular scattering, macular damage if it's done close to the fovea, and there is a chance of Bruch membrane rupture leading to CNVM. Now, this essentially has been replaced by the green laser, which is doubled Nd:YAG laser, 532 nanometers. Now, this is highly absorbed by hemoglobin and melanin, less so by xanthophyll. The Pascal laser or a pattern scanning laser, which is a very popular laser now, is one such type of laser which incorporates multiple pattern, short pulse, extremely short duration, 532 nanometer. Navilas is a navigated laser photocoagulator. Again, it is also available in the green laser module, which is essentially having into it.
Signal problem, I think.
I think we lost him, madam.
Ah.
I'll just go ahead with my talk, and once he comes back, Piyush is still there. Piyush? Must be some network issues.
Yeah. And we have 6 more speakers.
Yeah, I'll just go ahead with my talk. I'll quickly finish it. Is it visible, madam?
Yes.
Yeah. So quickly, I'll run through the part of anti-VEGF. Now, why is this question? Because this has already been asked in the exam. You can see here what are the various types of anti-VEGF agents available, what are their pharmacological features, their role, their complication, and what is VEGF trap. This has been asked very recently in the recent papers. So whenever a question is asked like this, you always have to make your points like this, like what's the role of VEGF, type of anti-VEGF, classification, important, indication, modes, complication. Then you can answer that question very clearly. If it's a 10 marks or 20 marks question, it's always better if you write it in this way so that you will not miss the point here and there. Now, whatever might be the cause of the anti-VEGF, it acts mainly on the triad, three important things. One is against the angiogenesis, against the mitogenesis, against the permeability. So these 3 important, and what are my slides I have done is what you can put it in your exams and you can write it. So what is the role of VEGF? You should all know it's the primary driver for angiogenesis, like it inhibits apoptosis, cell growth, survival of the newly formed vessels. It includes mainly the VEGF-A. I'll be stressing only on the VEGF-A because it's the key regulator for angiogenesis. Now, if you mention what are the types of VEGF-A, it's always good. It's a bonus mark. You have VEGF 121, you have 165, 189, and 206. So what are the different anti-VEGFs available? Pigatinib sodium was the first one which was available. Then came ranibizumab, bevacizumab, aflibercept, brolucizumab. So a little bit of bonus if you answer a newer drugs which are in the pipeline. So how to classify? Just draw a simple diagram like this, a line like this. The one which is inside is intracellular, extracellular. So basically, majority of these like bevacizumab, ranibizumab, or the aflibercept, how do they act? By neutralizing activity. That means these are the free floating VEGF-As which are in the extracellular space, and these they try to attract with the VEGF-A and then neutralize, so that there will be no VEGF-A to sit on its receptor. So that is the first part. So majority of these drugs, they act on neutralizing effect. The second part is when they act on the receptor. So that is where it comes is the interference with the VEGF receptor activity. That is when the VEGF already comes and sits on its receptor, then it gets activated, the tyrosine kinase signaling starts. So what are the drugs which can stop at this level is vatinalib and pazopanib, which are still under trial, but it's very important to mention it. Once the tyrosine kinase signaling happens, then what happens? The vasopermeability starts, the proliferation starts, the survival, migration, ultimately leading to angiogenesis. So these are the important parts, and this is how you have to classify. One is a neutralizing activity. The second one is interference with the VEGF receptor. And third one is the degradation of mRNA. Like if already present, then how we can degrade it so that the further VEGF production doesn't happen at all. So the pigatinib is the first, which is of historical importance now, but it's very important to know because it was the first anti-angiogenic agent. So it's a dual mechanism. It acts on anti-angiogenesis and anti-permeability. Then we have bevacizumab. It's a recombinant humanized monoclonal antibody, which it's a full length. So it can attack most of the isoforms of VEGF, but most importantly, it's always better if you mention it's off-label used in ophthalmology. Then we have the ranibizumab, that is the monoclonal antibody. It's just a Fab fragment. So just if you mention it's a monoclonal antibody Fab fragment, that is good enough. It was approved in 2006. It's important. Some examiners are keen to ask when was it approved. It was mainly approved for neovascular AMD. So whenever a question is asked on any of these anti-VEGF, make sure that you mention these. So please draw a light chain, a heavy chain. Then it is linked with the disulfide bridge. Okay. To that attaches this antibody Fab fragment. Just three things: light chain, heavy chain, disulfide bond, and then a Fab fragment. This itself will give you fetch you a good marks. So it's basically produced using recombinant DNA technology in E. coli. So further for your understanding and not to mention it, see how they usually do these anti-VEGF. The light chain is taken, the heavy chain is taken. Okay. This is put in the gene of interest, say any vector. Like I just mentioned, like E. coli or any vector, AAV vector, whatever vector it is. So once it goes inside the cell, these selection of clones producing ranibizumab protein, the ranibizumab protein starts developing. Once you get that protein, then it's the upstream process, downstream process before you get a full molecule. So how does ranibizumab acts? Again, three things: inhibits vascular permeability, cell proliferation, endothelial cell migration. So now coming to the indications, there is a variety of indications for these anti-VEGFs, but most important you need to mention is the age-related macular degeneration. You can put n number so that you will get good marks. It can be a juxtafoveal, subfoveal, recurrent CNVM, myopic CNVM, idiopathic CNVM, inflammatory, PCV, refractive macular edema due to vein occlusion, pseudophakic macular edema. In case of diabetic macular edema, that is the CSME. Can mention it in case of idiopathic perifoveal telangiectasia complicated with CNVM, radiation retinopathy affecting the macula, choroidal mets. In case of ROP as well, Coates disease, VHL disease. Now people are using it in CSR as well. So these are the various other added indications apart from the main indications which I described in the previous slide. So they have started in glaucoma and cornea as well. So mode of delivery is again important. The most important mode of delivery we need to know is the intravitreal. And other thing we need to mention is the episcleral hydrogel implant, that is the sustained drug delivery. Now few examiners are very keen to ask whether it can be given intravenous or not. Yes, this is the trial called as the SANA trial, where they try to inject systemic Avastin in cases of neovascular AMD. Again, it's of historical importance, but it's definitely good to know. If you answer this, the examiner will be more happy when he asks this question. So what are the doses? Lucentis is 0.5 milligram. So always remember, it will always be in 0.05 ml only. So anything happens, it has to happen within this dosage. So the ranibizumab is 0.5 milligram, Avastin is done in 1.25 milligram. Complications, again, you can make a list of complications for these, but important to mention, you should not forget mentioning the endophthalmitis, intraocular inflammation. It can cause rhegmatogenous retinal detachment, vitreous hemorrhage, persistent floaters, raised IOP, RP tear or rip. Okay, so bevacizumab, as I said, it's again an advanced, which I said the third type of classification, that is when you inactivate the messenger RNA so that it prevents the production of gene products, that is inhibit the production of the protein, that is the VEGF protein itself. But what are the limitations? It can affect only the futuristic protein products, but what to the VEGF which are already there in the body? So still the trial is going on this. So again, answering the question which was asked about the VEGF trap, it's a fusion protein, right? So VEGF R1, R2 with a FC fragment of IgG. See, this is R1, R2, FC fragment of IgG. So these are the very simple diagrams which can be drawn in the exam. So why are these called as VEGF trap? Because the VEGF thinks, okay, this is my own receptor. Oh, this is R1, this is R2. This is my own receptor. Let me go and sit on that. Ultimately, it gets trapped. That's why it is named as VEGF trap. It's also called as the decoy receptors. That is, R1 and R2 are the decoy receptors. Just an example for you people to remember. What is this? Decoy Air Force One. We do not know where is Joe Biden sitting here, whether in this plane or this plane. So it's also called as the decoy receptors. So what are the indications? Again, DME, CNVM, vascular occlusions, which has been approved. Intravitreal dosage, its trade name is called as the Eylea, which is 2 milligram. Again, what I mentioned, everything has to be in 0.05 ml. So studies, if they ask about the VEGF trap, because they have already asked in that question, so I'm just mentioning that it's important for you in CNVM, you need to know a little bit about view 1, view 2 studies. Vascular occlusions, need to know about Galileo and Copernicus. When DME, then Vivid and Vista. So these are the 3 important studies which you need to know when the question is asked on VEGF trap. Now, a little bit about newer, longer anti-VEGF is the brolucizumab. That's the most clinically advanced single chain antibody Fab fragment, which has 2 FC domain. Okay. So what is important you need to mention here, it's the lowest molecular of all the anti-VEGFs available, and relatively number of molecules per injection is higher as compared to this. So they claim that it's a slightly higher potent as compared to the other anti-VEGFs. So what are the trials for this? Hawk and Harrier. I'll not go into the detail, but they have explained that it's a superior reduction in central subfoveal thickness. Fewer patients had IRF and SRF as compared to the aflibercept. So something new you need to know is the ranibizumab port delivery system, which is yet to come. It's just like a fuel tank. You just have your full tank and then go for a long drive, something like this. So they are looking into if this can act for at least 6 months. So that's the ranibizumab port delivery system. It's also called as RPDS. So what's the knock on the door? Last 2 slides. It's abicipar pegol, that is a designed ankyrin repeat protein. Then we have faricimab, that's by the Genentech, which is nothing but it's a neutralizing angiopoietin 2. And then combercept, that is a Chinese molecule which bind to the VEGF-A and VEGF-B as well as placental growth factor. It is approved as of now in China. So squalane lactate, I have been hearing it right from my undergraduation days. It's like a topical anti-VEGF agent, which they're trying to do it, but it's not successful. Another thing they're trying is the aflibercept hydrogel depot. It's similar, the 6 months delivery for the aflibercept. So last slide about biologics or biosimilar. When they ask, please just remember what is important here is a biosimilar is nothing but a biologic that is highly similar to the reference product with no clinically meaningful difference in terms of safety, purity, and potency. Like if you have a Mona Lisa painting, how similar you make the second Mona Lisa painting is just about biologics. That is the biosimilar. It's now booming up because of our Honorable Prime Minister trying to make more and more about the generic drugs. See, it has to match the peptide mapping, the CD spectra, the fluorescence spectra, what we call is the secondary structure, tertiary structure. It has to match the potency and the purity. Purity, like it has to undergo the cation exchange, HPCl, that is high performance liquid. So these are all the various things. So it has to be as similar to that of the innovator drug. That itself is the biosimilar. Okay. So the few examples, you have bevacizumab as Zybev, we have biosimilar ranibizumab, and that's it. I'll not go into the details of it. Thank you very much for the patient listening.
Thank you, Srinivas. That was a brilliant talk. And as an anterior segment surgeon, I was really lashed onto every slide of yours. Very, very interesting and useful. Maybe this is not a postgraduate PG related question, but more for my information. When would you think of sending it to the glaucoma surgeon or the IOP rise with these? Would it be with just one odd injection, or would it be with multiple injections you would consider? Would you consider it more for the one of which group of drugs?
See, usually if the patient is a known case of glaucoma, then we usually go in for the first choice is anti-VEGF and not the steroids as well. But in those cases, usually what we try to do is you can make an AC paracentesis, try to decompress the volume, and then you can go ahead with the injection of the anti-VEGF. Or if the patient is already on the anti-VEGF, then you can always go in through after 5 minutes, you can just check for the pulsations of the central retinal artery. If there are any of those kinds, then you can always try to decompress so that the patient will not go in for the more glaucoma field defects.
No. What my question was, would you look for glaucoma if there are multiple injections needed, or with just one odd injection itself, you expect an IOP rise?
Sorry, I'm not getting your question, madam.
With anti-VEGFs, you won't get an IOP rise.
Yeah.
It's only with steroids you have a problem of.
There are some studies, basic science studies, which suggest that like a large number of injections, when they given after numerable injections, there can be trabecular beam damage, and that can cause IOP rise even after anti-VEGF injections.
Yeah,
most of them are basic science studies. None of them have shown clinical
significance. It's not a routine thing, and you're not going to do it as a clinical practice before when you're starting off the treatment.
Yeah.
There are a few patients. I remember only isolated patients whose IOP has actually risen following multiple injections. Otherwise, very rare for that to happen.
Yeah. Most we see it in the steroids and not in the anti-VEGF.
Yeah.
So brilliant talk. There's no questions for you. We shall go on to our next speaker, Dr. Piyush. Will you take on from where you had left? Because we do have 6
Piyush, you have to start from where you have left, not from the beginning.
No. And we have 6 more speakers, so we'll have to sadly.
You don't want us to have dinner, no?
Oh, discussions might have to be sadly curtailed. We should have been more sparing initially. I do want to do justice to all the other speakers. So start off, Dr. Piyush.
Yes. So I just spoke about yellow laser, which was 577 nanometers. It has good penetration through media opacity and less absorption by xanthophyll. So treatment can be achieved closer to the fovea. Now, various laser delivery systems are available. The most common one being.
Slides are not shown.
Am I audible?
Oh, yeah.
Yeah, your slides are not seen, but you can still go ahead, Piyush.
Okay, so the most common one being slit lamp laser delivery system, which is comfortable both for the doctor and the patient. The next one would be a fiber optic cable attached to an indirect ophthalmoscope. This is essentially very useful for treating peripheral lesions. The third would be endophotocoagulation, that is used during during surgeries, during vitrectomies, for retinal detachment and for vascular disorders. These are the various lenses that are used for laser delivery. Now, it's important to remember that the image magnification and the laser spot magnification changes according to the type of laser used, either for PRP or for macular laser. The parameters that one has to keep in mind are the power, spot size, duration, interval, and the number of burns. This is a gradation of the density of coagulum, which changes depending on the condition being treated. Now, coming to the common indications, panretinal photocoagulation is the most common indication, and it is the most common indications for PRP being PDR, severe NPDR, ischemic CRVO, ocular ischemic syndromes, and peripheral disorders. Now, coming to proliferative diabetic retinopathy, what happened? Are my slides seen?
No, not seen. I couldn't understand why Srinivas let you off.
No, Piyush, what we can do is, we'll finish, you just figure it up. We'll finish this talk and we'll come back again because there is some problem. We're not able to see your slides.
All right.
Good to hear you. This is unfortunate. So
yeah,
we should.
Madam, you go ahead with the next. We'll come back to PPT.
Yeah. Our next speaker is in the next section, how to approach, is Dr. Dipti Kulkarni, who is a consultant vitreoretina surgeon with areas of interest in diabetic retinopathy, preventable retinal blindness, ROP, glaucoma, and is an essential part of our team at the AMEA Lasers and Research Private Limited. She is going to be talking on how to approach viral retinitis. On to you.
Ma'am. I have tried to address this mammoth of viral retinitis in a small bunch of slides. First of all, why is it important to know about viral retinitis, both from our OPD practice point of view and exam point of view? Mainly the diagnosis is clinical. All the tests that we do are either to support this or to confirm it if we want to do it. And secondly, if not treated, this can spread rapidly and cause permanent debilitating blindness in a matter of days and weeks, and sometimes hours if RD develops. Now, this is the real reason why we need to know about various viral retinitis. This is a bunch of photos which has a few cases of viral retinitis, infective retinitis, and some are even non-infective cases. So when we don't know or when we are not aware of what we are trying to look at, everything will look the same, red and white. So these are the actual cases that I had posted in the previous slide. Let's just move on. In the history, we must make it a point to note that the vision loss in these cases will be sudden and severe. There will be some amount of pain, mild or severe, depending upon the condition. The patient can complain that he has a pain while moving his eyes. Photophobia can be there. We must make it a point to note the immune status of the patient. If he's already a known case of HIV, then a CD4 count must be documented or noted. The patient might give a history of herpes simplex or zoster. If not, then we must ask and make a note of it. Now, what are the differential diagnoses that we are looking at when we are looking at cases of viral retinitis? Viral retinitis can either be necrotizing or non-necrotizing. The necrotizing ones are ARN, PORN, and CMV retinitis. And herpes can also cause a non-necrotizing type of picture. The other DDs that we must look at here are toxoplasmosis, syphilis, Behçet's, and like I shared in the previous slide, other diagnoses that can give us a red and white picture. I've added small tidbits of what we must study as we go along in the slides. All of us know that these are the highlights that we have to look at when we study any case. But what I want to stress here is that we must know the differential diagnosis, not just for the entire picture, but for each finding per se. I'll elaborate as we go. This is again another Pehchan cone. There are two photos here of infective retinitis or viral retinitis and two which are not infective at all. So let's first look at CMV retinitis. Cytomegalovirus is again a type of herpes virus which is slowly progressive. We must note here that this mostly occurs in immunocompromised individuals where the CD4 count is less than 50. Patients will complain of a drop in vision which is sudden and severe, like I said. Sometimes then the cytomegalovirus is of the indolent variety where the lesions are peripheral. The drop in vision might not be as severe as we expect. This is classically called a pizza pie or cheese and ketchup appearance because of the retinal whitening and the hemorrhages. In cases of congenital infection, we must also note for presence of fever, anemia, or pneumonia, hepatosplenomegaly. And although even if the cases don't show retinal involvement at the outset, they need to be monitored because retina can be involved even at a later time. The clinical findings are either there is mild or very absent vitritis. The white lesions are the cottonwood-like spots, which are the areas of active retinitis, and they spread with the leading edge where there is intraretinal hemorrhage. Papillitis and vascular sheathing are prominently noted here. And in many cases, when the patient has not presented to us early on, we can see him directly in the stage of dermatogenous RD. Now, CMV I have two presentations, either a classic or a fulminant one, or the peripheral or granular one. In the classic presentation, the posterior pole is mostly involved. It is very aggressive and large hemorrhages with wide areas of necrosis are seen. And in the peripheral presentation, this is a lesser aggressive version. There is little or no hemorrhage, and after healing, there is a presence of pigmentary changes. At this point, I would like to say here that we must know other causes of pigmentary changes that are seen in the retina. Fundus photography is essential here because we want to monitor to know the progression or the effect of our treatment. HIV testing and CD4 count I have already mentioned. PCR testing is just to confirm our diagnosis, but if we want to confirm the diagnosis in children, then PCR of the urine or saliva is done, and if required, then subretinal fluid.
Your slides are not moving.
Okay. Okay.
Can
Are
you
they
just-
moving now?
No, it is still stuck in the cytomegalovirus retinitis, the first slide.
Okay. So I'll escape this and I'll go like this. Is this okay?
Yeah, sure.
Stop the screen share and you can share it again.
Yeah, okay, okay. Sorry for this.
Yeah, that's okay.
No worries. So I would like Dr. Muralidhar sir to please moderate after this talk.
So I had reached the stage where I was showing this, where the fundus photography was required for monitoring both the progression of the disease and also the effect of our treatment. CMV can also present.
Dr. Kulkarni, your screen is not visible.
Screen is not seen.
Can you just stop share and start again?
You can do it because the bandwidth, I think, is not allowing you to slide share and also beam your video.
Maybe
okay.
Stop your video and just share.
Yeah.
I think it will help you in presentation.
Yeah.
Is it visible now?
No, doctor.
It was visible earlier on.
It is. I can see it as you are sharing screen.
No, but it's not visible. So, Sunil, I think, is it something to do with the bandwidth?
Yes, sir, and probably she will have to log out and log in again.
Okay, I'll do that. Meanwhile, you can carry on with.
Next, Madam Tirumalesh, Madam Chitra, Madam.
Yeah, we'll go to the next speaker and we'll come back to you, Dr. Dipti. Our next speaker is Dr. Tirumalesh, who's going to be delving on post-op endophthalmitis, which is definitely going to interest us all. He's a leading vitreoretina surgeon with special interests in minimally invasive vitreous surgeries and complex retinal procedures from Narayan Nethralaya, Bangalore. On to you, Dr. Tirumalesh. You could share.
Thank you. I hope my slides are visible.
Yes. Go into the slide shade, Thiru. Yeah. See.
Thank you very much for this opportunity, Dr. Srinivas, Dr. Yes, I'll be talking about postoperative endophthalmitis, and the topic that was given to me was how I manage. So why I put up these slides was that, this is how endo would present, and microbiology plays a very important role in how we go ahead with treatment. So the initial part is making the diagnosis. As we all know, endo by definition is an inflammatory process which is secondary to an exogenous infection entering the eye, most commonly in the postoperative period. So it commonly presents with circumciliary congestion. There will be some amount of media haze. Patient comes with pain, blurring of vision, hypopyon or AC reaction, and lid edema. And it's by no conjuncture that these were also the mentioned signs and symptoms in the EVS, the circumciliary congestion being the most common at 92%, followed by media haze. And pain, lid edema were seen in 30% and about 12% respectively. So once we arrive at a diagnosis of endo, one other thing that you should consider that, whether this particular patient has an infective etiology, or is it a TARS, or is it postoperative reaction. So the concept of postoperative reaction is if the pupil is stretching or there was a lot of iris prolapse, then directly you know that you have manipulated. So some amount of inflammation is something that you would expect. But however, in an uneventful surgery, if this is the picture, then you should consider either endo or TARS. So how do we differentiate? TARS is, as the name indicates, it is an anterior segment shock syndrome. So most commonly it is seen on post-op day 1. However, endo is seen after 4 to 5 days. Congestion is usually not there. Congestion is the most commonly seen sign in endo. Pain is usually absent. Endo is usually painful. Corneal edema is diffuse from end to end, white to corneal, white to white. However, patchy corneal edema is a characteristic feature that you see in endophthalmitis. So how to differentiate with more certainty whether it is TARS or endo is that you do an ultrasound. When there was an anterior segment reaction and you see this kind of picture on the ultrasound, it means that you are dealing with postoperative endophthalmitis. Now, what is next is after you have documented all these signs, either through a clinical picture or a very good fundus drawing, because it's, these are the patients who will require follow-ups, and also prognosis is not going to be too good. Second thing is do a ultrasound examination serially, which will again be required. So the first one should be documented and, stored in the file. Second thing is you discuss the treatment option to the patient that, initially we will try and manage with injection. If required, surgery may be required. And at every step, which will be guided by microbiology samples. Why I'm stressing on microbiology samples is because it will deal with what kind of antibiotics we are going to give with. So when the vision is counting fingers or better, so my initial plan will be, I will plan an intravitreal antibiotics. Usually antibacterial is the one that I would consider. However, because we have an in-house lab and we can process the sample within 5 to 10 minutes, what I do is I give a block to the patient and I take a insulin syringe with 26 gauge needle with the piston out. I do an AC tap and I send it to the lab. So in the meanwhile, the lab will tell me whether, by doing a gram stain and KOH, whether it is bacterial or not. Usually, within a few minutes, we are notified. If they find that it was, a gram positive or a gram negative cocci, or gram negative bacilli, and considering that it is a bacterial this thing, so I would probably inject ceftazidime 2.25 mg along with vancomycin and DEXA. If the gram stain does not yield any info, I would still go ahead with injection of ceftazidime and vancomycin. I would omit DEXA, and the patient is reassessed within 48 hours. If it is worsening, then vitrectomy is something that I would consider. However, these are the reports that usually our lab sends us a message immediately when we send them. If you see that there is gram-positive cocci or polymorphs, it literally confirms that it is bacterial. However, gram stain also can detect, fungal yeast like this thing, and also hyphae like you see in the second picture. However, KOH and calculaphore will, combined staining will, increase your detection rate of fungal hyphae, as you can see. So what I would do if I don't get this, before I inject, I usually use a 24 gauge needle and take a vitreous sample and I send it for culture and also for PCR. So why did we choose ceftazidime and vancomycin is not just along with the EVS trial, but also recent cultures of, quarterly when we do, we keep a note of that. And you can see that ceftazidime shows about 70% sensitivity for gram-positive cocci and gram-negative bacilli. And if you combine that with vancomycin, which has a 50% coverage, then you are almost including majority of the spectrum of the bacteria. Another important thing is, if you consider piperacillin and tazobactam, which can be injected at 2.25 milligram per 0.1 ml, it seems to have a very, very broad coverage. And this has been worked upon by the LVPI group also. However, if the microbiology, report says that, we could see fungi or, hyphae on the KOH and also on the grams, then I would switch over and I would probably use voriconazole, which is 100 micrograms per 0.1 ml, which is injected. And before injection, like I told you, I would also use a 24 gauge needle and send it for culture for further confirmation of the microbiology. If the microbiologist is very sure that, it is candida, where you can see gram positive, yeast, which usually turn gram positive, then I would probably switch and consider using amphotericin B at 5 microgram per 0.1 ml. And I usually omit injecting Cefta, Dexa or Vanco because I know that it is fungal end off. However, if both have been negative on the anterior chamber examination, then probably I will go ahead by only giving antibacterial in the first one. If the patient's presenting visual acuity is hand movements, closed face, or if the patient is only PL+, then I would usually consider doing a vitrectomy. So how would I proceed is, I usually put an infusion port. There is a 6 mm 23 gauge port which is available in the trocar cannula. I use direct perpendicular entry at 3 millimeters, considering the patient is postoperative, maybe usually has a good pseudophakic, and you are in the pars plana as well. After putting this cannula, I usually take a sample from the aqueous. I also remove the membranes over the IOL and I immediately send it for microbiology. And I also use the other port before switching on the infusion. I collect about 200 microliter of aqueous and send all three together for microbiological examination. By the time I do vitrectomy, I usually get a report. So usually I do a core vitrectomy. Vitreous I will debulk as much as possible. I never attempt a PVD when I'm doing vitrectomy in an end off. Once the retina is fairly visible and I have adequately debulked the vitreous, I do a partial fluid air exchange and inject antibiotics. However, if the underlying retina appears a little necrotic, or you see that there is retinal edema, then I usually inject silicone oil because I want to be a little more safe on the safer side, because it will help me evaluate the retina in the postoperative period. Then I switch over to the postoperative antibiotic and steroids, which are initiated, and I keep the patient on a close follow-up. Now, endovitrectomy study is the most important study, which, in spite of two decades, being 2 decades old, is still the one which guides us in treatment. This was an investigator-initiated trial which had taken 420 patients across 25 centers in the US, and they had randomized into 4 groups. So all patients, although received in intravitreal antibiotics, there was one group where vitrectomy with systemic IV steroids and intravitreal antibiotics was given. There was one group where vitrectomy with only intravitreal antibiotics was given. There was a group where vitreous tap was done with antibiotics, and the 4th group where vitreous tap was done with intravitreal antibiotics and also IV antibiotics. So the intravitreal antibiotics that they chose was amikacin at 0.4 mg and vancomycin at 1 mg, which we also currently use. What were the intravenous drugs that they used for 5 to 10 days in the 2 groups that they were randomized? Was that they used IV antibiotic, which was ceftazidime, which was 2 grams every 8th hourly. And whenever the patient was sensitive, they switched over to ciprofloxacin 75 mg, which was given twice orally. The second systemic drug which was used in the EOS trial was amikacin. So you can see that amikacin was given at 7.5 mg as an initial dose, and they were monitored by serum levels because amikacin can be known to be a toxic drug. So what did the EVS tell? Was that with reference to media clarity, a significant greater percentage of patients in the WIT group actually had better media, which was 86 versus 75%. However, if you look at long-term follow-ups, the difference was not very significant. That even the vitrectomy patients had 90% clear media. However, the TAP group, TAP and inject group had 83. Systemic antibiotics, whether it was ceftazidime, amikacin, or ciprofloxacin, they did not have any bearing on the final outcome. There was also more rapid clearing of the media in the WIT group, although it was not associated with concomitant rapid improvement in visual acuity, which means that clearance of media does not mean the patient is also going to get excellent vision. So continuing with the EVS recommendations are these, that it strongly supports the use of vitrectomy after cataract surgery only in the patients who has PL vision. If the patient is having any kind of counting finger vision, those should be considered to give intravitreal antibiotics. The study also found no advantage in performing immediate vitrectomy. I'll finish in 30 seconds. However, vitrectomy was value in patients where severe visual loss was halved. You can see that in 15% in the TAP group had severe visual loss. However, only 8% in the WIT group had better vision. So how does it translate? Is that whenever you get a one-eyed patient, probably it is better to do a vitrectomy at the initial. This is a small video of 30 seconds. So whenever you get a patient in the postoperative period, like you see that if this patient had undergone a K-Pro, where you cannot monitor anterior segment signs, and usually K-Pro is done in one-eyed patients. So these are the patients who you would like to directly take up for vitrectomy. So once you clear off the retroprosthetic membranes, so you can see that there is a lot of vitreous exudation which is there. So I usually do a vitrectomy where I only do a debulking. I never use any pull technique. So once you start debulking and the retina is relatively seen, you can just trim the vitreous. Even in small pupils also with the current visualizing system, you can see most of the peripheral vitreous. So once this is done, you can either decide on doing a partial FGE and putting an antibiotic. If the retina is bad, then one would probably want to inject silicone oil. So that was my time. Thank you very much.
Very good, wonderful presentation. It was really enjoyable and learned a lot again and again. There were many questions in my mind. Everything got cleared up. So one last stupid question I have is there retinol or systemic antibiotic, or in a very virulent case, would you think of giving an antibiotic which is same as what you gave intravitreally?
Ma'am, actually, if you look at many retinologists, my mentors also used to use systemic antibiotics. Many people thought that ciprofloxacin or usage of Dr. T.P. Das has a publication where they say that usage of fluoroquinolones has raised the intravitreal concentration to MIC levels of more than 50%. But however, the EVS had given the same dosage. Ciprofloxacin was used at 750 milligram on a BT dosage, but they did not find any improvement. So if you are looking at evidence-based, 2 decades ago, they proved that they don't have any role.
I think the important thing is that if you're giving intravitreal antibiotics, then the intravenous antibiotic does not add to the levels. But if you're not giving intravitreal antibiotics, that's not so. That's number one. The second thing is that if you're putting silicone oil inside the eye, then the levels will change. Then this thing does not apply. EVS is only applicable to eyes which have had a conventional vitrectomy. In eyes which have had silicone oil with injection with vitrectomy, we found that the levels double. They become almost parallel to the systemic levels that you get. So in those cases, there is a huge difference. That paper is published in IOVS.
A quick question to Muralidhar sir, and then we can go on to the next talk. Sir, in case of these endophthalmitis with silicone oil, which Thirumalaish has nicely mentioned, and he has elaborately told about the steps, what he does. In silicone oil, do you decrease the dosage of these antibiotic injections, or in which cases do you prefer using silicone oil? And what's your dosage of the antibiotics when you use silicone oil for endophthalmitis?
I prefer to use silicone oil in severe end-off, especially post-traumatic end-off, where there is a lot of vitreous change and possible retinal detachment. In those situations where the retina appears necrotic, as Thirumalaish said, I would prefer to use silicone oil. And regard to the antibiotics, generally I use half dose of the dose that we normally use in a non-silicone filled eye. So that means if you are using 1 milligram vancomycin, I use half of that dose. Generally ceftazidime or vancomycin, I would use half dose in a silicone filled eye.
Thank you. Thank you, sir. Thank you, Thiru. Wonderful presentation. We can go on to the next talk, madam.
Would we go back to Dipti or?
Dipti, are you there?
Yes, I'm there. Yes.
Yeah.
I'll try it this way without the video. If it works, well and good. I'll begin where I stopped. Can you see the slides now?
Yes.
Okay, so I had stopped at management of CMV retinitis. The dosages and detailed discussion I'll skip for now. I'll just like to add here that there is a loading dose and there is a maintenance dose. So for both, for oral, systemic antivirals and intravitreal, once we see a retinal detachment, a pars-plana vitrectomy becomes imperative. The intraocular therapy with the intravitreal ganciclovir or foscarnet is followed initially thrice weekly or bi-weekly, and once the lesions start to respond, then then it is shifted to weekly. It is important to know a couple of side effects of each of the drugs that we are using. So when you are studying this, please make a point of those points as well. Drug resistance here must be noted. That is why is it seen now?
Yes.
Okay, so drug resistance is noted. That is why maintenance therapy and a combination of systemic and intravitreal tends to be more effective. This is the next Pehchan Con. I am going to be talking on PORN, but like this slide shows, it can be quite confusing if we don't know what we want to look for. PORN is another condition which is precipitated by herpes viridae, and this can be unilateral or bilateral right from the outset itself. It is seen in immunocompromised individuals again. We can see here that the vitritis or any sort of inflammation is conspicuous by its absence. The lesions start in the periphery or the macula. Initially, there may be single lesions which later coalesce to form 360-degree lesions. There can be a motile pigmentation after healing. And I would like to stress again here that there is no inflammation. So no vasculitis, no hemorrhages, and we can see that the veins are spared. Here we should know the other causes of retinal whitening and other causes of what can cause a motile pigmentation in the retina. This is again a clinical diagnosis. This progresses rapidly and causes blindness in weeks if not treated. Here too, intravenous and intravitreal therapy as a combination works well, and when retinal detachments are seen, vitrectomy is advised. This is the same again. I would just like to stress on the point of barrage laser here, that when we see the lesions are healed, then we'll do a barrage laser in the healthy retina just within the margins, just in order to prevent progression of the retinal detachment if at all. But inevitably, if it progresses, then we have to do a vitrectomy. We will see ARN next. So this is what it can mimic ARN. ARN is again caused by herpes viridae. Here there is full-blown inflammation in the anterior segment, in the posterior segment. The vitritis can be so dense that the retina may not even be seen. The KPs are large, granular, and sort of multiplied KPs. The retinitis here is necrotizing. There is obliteration of the smaller arterioles and capillaries by thrombi, which cause retinal necrosis. Immunocompetence here is the hallmark, because even if the patient is a known case of HIV or other conditions, there is a good CD4 count and the immune system is functioning well. But some studies have shown that this can be seen in other systemic disorders like diabetes, or if the patient is on some long-term medications, or as a telltale sign of malignancy. This criteria can be found in any standard textbook. We'll skip this slide. This again follows varicella zoster or even herpes simplex virus. Like I said, that there is dense vitritis, lesions are peripheral and discontinuous, and they coalesce quickly to form full thickness necrotic areas, arteriolitis, phlebitis, and hemorrhages as well. The mid-periphery tends to get necrosed very often, and there are multiple posterior breaks which cause retinal detachment. And although the posterior pole might appear to be spared, there is very poor prognosis here because the optic nerve gets involved quickly, and the RD is very indolent to treat. PCR again of the aqueous or vitreous can be done here to confirm what virus was there. Treatment of ARN again is with IV cyclovir. And in this case, after 24 to 48 hours of starting the antiviral therapy systemically, steroids are started to curb the active inflammation. These steroids need to be tapered very slowly along with the maintenance dose of the antivirals that we are using. In this case, one point to note is that aspirin is used to treat the thrombotic occlusions, or rather to prevent further.
Doctor, time is up.
In the retina. Prophylactic laser, like I mentioned in the previous case. One last slide of non-necrotizing herpetic retinitis. This is seen in patients who following varicella zoster infections. Initially, it was seen mainly in children, but now with the advent of HEART, it can be seen in adults as well, whose immune status here rather is immaterial. Even if the patient has a good immune system, you can still develop this. There is acute retinochoroiditis with diffuse hemorrhages, but there is no necrotic retina here. It presents bilaterally most of the cases. It is tend to be treated as a non-infective case initially, and seeing there is no response, it sometimes foxes the clinician. But once oral antivirals are started, this responds very well, and then rather we can come down to the diagnosis of non-necrotizing herpetic retinitis here. Thank you, and sorry for the interruption.
No. That was a very good talk, and you tried your best to keep it as concise as possible. I think we would go on to our next speaker. I'm sorry. We go on to our next speaker, Dr. Manoj, who's a senior consultant, vitreoretina and uvea services, neuro-ophthalmology and electrodiagnostics from a very well-known chain of Chaitanya Group of eye hospitals based in Trivandrum. He is going to detail on wet AMD. On to you, Dr. Manoj. Could you share your screen?
Yeah, I'm just about. Can you see my slides now?
Yes, sir.
We are able to see your slides. Go ahead, Manoj.
Thank you, AIOS-ARC for this opportunity. Thank you, Srinivas. So what I'll be trying to do is to try to actually talk to you, from the PG point of view, how to approach a case of wet AMD. I would focus on how to make a diagnosis more than how to treat. Just touch upon how to treat, but then I would be focusing on how to approach a case of wet AMD. Now, this is the definition. Age-related maculopathy is defined as a degenerative disease in individuals over 50 years, characterized by drusen's of more than 63 microns with pigmentary changes, retinal pigment epithelial atrophic changes, or exudative changes in the absence of other retinal disease. The classification is this. We are more bothered about wet AMD here. So this is part of late ARM. And exudative AMD is otherwise called as wet AMD, and this is characterized by presence of coronal neovascularization, pigment epithelial detachment, and disciform scar. Now, under coronal neovascularization, we have these three important entities: typical AMD, polypoidal coronal vasculopathy, and retinal angiomatous proliferans. Now, this is the drusen's. So, patients with typical AMDs should have drusen's. They should have drusen's in the same eye which has the CNV, has the exudative process, or they should have at least these drusen's in the other eye. So you look for these drusen's, and especially if you see these large kind of drusen's, which are more than 125 microns, or drusen's which are in the size of more than 63 microns, it is significant. Now, wet AMD manifests in the form of PEDs. PEDs, you can see serious PEDs on clinical examination, which are fluid-filled RP elevations, or you can have hemorrhagic PEDs. You can also have drusenoid PEDs when the drusens become confluent. And then you can also have the fibrovascular PEDs, which are nothing but harboring neovascularization. And the hallmark of wet AMD is the presence of choroidal neovascularization. When you do a good 90-day examination or a 78-day examination, you could make out these membranes. Sometimes they are ill-defined, and sometimes you see them well-defined. When it's well-defined, they're usually classic CNVMs. When they're ill-defined, it is usually occult CNVMs. And these membranes usually have exudation around it, and also hemorrhages. The hemorrhages are usually subretinal. You can also have sub-RPE hemorrhages. You can make this difference from the color. You can also have pre-retinal hemorrhages in some instances. And the entity that closely mimics the typical AMD is polypoidal choroidal vasculopathy. How do you diagnose this? When you do your clinical examination, if you see orange-red nodules that are seen in the macular region, they are suggestive of polyps. You see polyps, or if you see these large drusenoid deposits, which are also called as pachydrusens, or if you see subretinal hemorrhages, which are like in the range of around 4 disc diameters, these patients are most likely to have polypoidal choroidal vasculopathy than typical AMD, and many of these patients have both mixture of both exudative as well as hemorrhagic forms. Again, when you see a patient where you have a lot of peripapillary lesions around the disc, or if you see peripheral lesions, then this is likely to be PCV. AMD patients have lesions in the macular region only, and as I said before, you see drusens that are associated with these lesions in the same eye or in the other eye. And again, scarring is a process that is commonly seen in AMD patients and not seen very often in PCV patients. Again, if the age of the patient also could give you a clue, PCV patients tend to be a little younger than AMD patients. Retinal angiomatous proliferance is another type of wet AMD process where these patients have intraretinal hemorrhages, not subretinal. They have intraretinal hemorrhages, usually along with pigment epithelial detachments. And also you can make out the presence of a retinal anastomosis or a retinochoroidal anastomosis that can be seen during a clinical examination. So when you see an obvious CNVM, you think of these three entities. You try to fit them into either typical AMD or PCV or RAP first based on the clinical examination. If you cannot put them in these three categories, you are probably dealing with a secondary CNVM. These are the entities which are commonly associated with secondary CNVMs. FA remains the essential investigation. So if an examiner asks you what is the first investigation that you would do, it is better because many of the examiners, the old examiners would like to hear FA first. So it remains the essential investigation to diagnose and assess disease activity. And this has already been elaborated before. You have to tell the examiner that you will be looking at the early phase of the FA and the late phase of the FA. If you see a membrane that is appearing, well-defined membrane that is appearing in the early phase of FA, and then this membrane becoming very leaky, the late phase of FA, you are dealing with a classic CNVM. If you see an ill-defined membrane in the early phase of the FA with some leakage in the late phase of angiogram, you are probably dealing with occult choroidal neovascularization. Now, the next question that examiners can ask you is, what are the indications for ICG angiography? So whenever you're suspecting PCV, so based on the clinical suspicion, if you're suspecting PCV, this is an indication for ICG angiography, because ICG angiography is the diagnostic investigation for PCV. Again, in patients where you suspect RAP based on clinical examination, ICG has a major role to play. In occult choroidal neovascularization also, ICG has a role to play, especially when you are dealing with a poorly responding choroidal neovascularization. You should be aware of this classification of occult CNVM based on ICG. This is classified into plaques, hotspots, and combination lesions when you have a combination of plaques and hotspots. Now, if you get an ICG picture, how do you identify an ICG picture? If you look at the disc, you see this, the blackness of the disc tells you that you're dealing with an ICG picture. So what should you look at when you see an ICG picture? First, look for these hot spots. You see these hot spots here. If you see multiple hot spots, you're probably dealing with polypoidal choroidal vasculopathy. If you're seeing a single or a focal hot spot, you're probably dealing with a typical AMD or even a retinal angiomatous proliferance. In RAP patients, you can see that the angiogram demonstrate the presence of retinal anastomosis or the retinochoroidal anastomosis as well. Patients with occult CNVMs, if you take an ICG, often you see this plug appearance. So plug is an important feature that you see on ICG angiography. ICG angiography in the early phase, you can also pick out these membranes. So look for membranes, look for hot spots, look for plugs, look for membranes on the ICG pictures. When you see membranes associated with hot spots, then you should understand that this is probably a patient with PCV. The PCV patients, this is a branching vascular network with a polyp that you see. The OCT is currently the most popular in
So 1 minute left.
Sorry?
A minute left, sir.
Yeah. So OCT helps us to differentiate between classic and occult CNVM. When you see this reflectivity lying above the retinal pigment epithelium, then this is a classic CNVM or a type 2 CNVM. When you see it lying under the retinal pigment epithelium and the retinal pigment epithelium is elevated, you are probably dealing with an occult choroidal neovascularization or a type 1 CNVM. And so these are types of PED. So when you see PEDs like this, when you see this configuration, a thumb-shaped PED or a massively diffusely enlarged PED, or when you see multiple notched PEDs or a tent-like PED with internal reflectivity, so these are OCT findings that are suggestive of PCV. In patients with retinal angiomatous proliferance or type 3 CNVMs, the characteristic OCT finding is a serous PED with a reflectivity about, and often you see a lot of intraretinal fluid. This is a characteristic OCT picture that can be kept, which is suggestive of type 3 choroidal neovascularization. Again, looking at the choroid may help you to understand. If you see a thick choroid like this, which is referred to as pachychoroid, then you're probably dealing with the polypoidal choroidal vasculopathy. But like you see in this picture here, the choroid is thinner with an overlying pigment epithelial detachment. This is suggestive of typical AMD. So looking at the choroid will also help you to differentiate between typical AMD and PCV. The third thing that you need to look at in OCT is to define whether the disease is active or not. When you see fluid in the OCT, intraretinal fluid, a subretinal fluid, then you know that this is an active CNVM process. If you don't see fluid, it is probably an inactive process. Again, multimodal imaging is a useful tool sometimes in differentiating these patients. Like in this patient here, you see a lot of angiographic leakage, and you also see something like a fluid here. But this patient on autofluorescence showed the increased autofluorescence here. This is a adult vitally formed dystrophy, which looked like CNVM. So mimics of CNVMs may need multimodal imaging to clarify. OCT angiography pictures also can be kept now for examination. So this is these are pictures of OCT angiography where you see this neovascular network. There are some classifications based on OCT angiography, and this helps us to understand whether it is an active disease process or an inactive process. Active disease process have a lot of anastomotic channels along with main trunks, whereas the inactive disease, they do not have a lot of anastomosis. That helps us to differentiate whether it is an active CNVM process or not. OCTA is also useful in patients with RAP because it helps us to identify that the neovascularization arises from the retina and not from the choroid. Finally, this is how we would approach a case of wet AMD. The first step one is to identify what is the type of wet AMD based on clinical angiographic and OCT characteristics. And sometimes you need to resort to multimodal imaging in doubtful cases. Step two is to identify whether it's an active or inactive disease, and thereafter the treatment plan is adopted. You always look at the other eye because the presence of drusen's and other findings on the other eye will help you make a diagnosis. Just to touch upon treatment, anti-VEGF therapy is a mainstay of treatment. So if they ask you how would you treat this patient, be it PCV or be it AMD, you can say that it's anti-VEGF therapy is the main mode of therapy. They would like to know what are the names of the drugs that are used, that is already covered. What are the strategies that are currently available? You can talk about monthly injection or a PRN injection or what is called as a treat and extend injection. You should at least know what these means. In PRN injection, patients are examined periodically, and injections are given depending on the disease activity. If there is disease activity, give an injection. If there's no disease activity, don't give an injection. In treat and extend, what you do is you give an injection and you extend the injections at 2 weekly intervals to a maximum of 12 to 16 weeks. So at least you should know these terms. Patients with polypoidal, if you think you are dealing with a polypoidal choroidal vasculopathy case, you can either say that you would be using monotherapy, that is only anti-VEGF agents, or you would combine anti-VEGF agents with photodynamic therapy. Thank you.
Thank you very much, Doctor, for a very detailed talk. Paucity of time, we're not going to take discussions. We go on to our next speaker, Dr. Manish Bapai, who is going to be dealing on posterior segment trauma. Dr. Manish, could you share your screen? He's a very versatile, amazing surgeon managing vitreoretina, uvea, neurophthal, trauma, cataract, and LASIK. Clearly shows he's an individual of tremendous skill sets. So let's hear from him.
I think after these 3 talks, we can have the discussion, madam.
Yes, sure.
Good evening, everybody. Thank you for opportunity, madam. I'll be talking about assessment of the posterior segment trauma. Just try to go to. Give me a second.
So just put it in presentation mode, sir.
Yeah.
On the bottom right.
I think this thing is not going down, so I'm not able to.
Just press F5.
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 Okay,
just stop and share again if you can.
Yeah, I'll stop and share again. Just give me.
Have you? Yeah.
Just give me a minute.
Yeah, sure.
Is it visible now?
Yes.
Good evening, everybody. I will be talking about assessment of posterior segment trauma. At the outset, I would like to thank ARC, thank Dr. Chitra Madam and Srinivas for giving me this opportunity. So, when a patient with trauma comes to your clinic, there are certain things that we should be knowing. There are certain things that as postgraduates we should be knowing. One is ocular trauma classification terminology as to what is an eye wall, which is sclera and cornea, closed globe injury where the eye wall is not breached, open globe injury where it is breached, whether it is rupture which happens because of blunt trauma, severe blunt trauma, laceration which is usually because of sharp object, which is a full thickness eye wall injury, penetrating injury where there is a single laceration, while the perforating injury where there is a entrance and exit wound, and intraocular foreign body when there is a retained foreign object inside the eye. The more common trauma among the trauma is blunt ocular trauma, and easy way to remember the 7 rings of blunt ocular trauma, which will give us a clue when we are treating, when we are assessing these patients. There is pupillary sphincter tear, iridodialysis, angle recession, cyclodialysis cleft, trabecular meshwork tear, lens zonular dialysis, and retinal dialysis. So when we are seeing these patients, when we are evaluating these patients, we have to take the history, a detailed history, whether it's a penetrating or blunt trauma. We have to make sure that medical legal consent forms are filled, whatever are relevant to your institute. The visual acuity has to be checked. That has to be the first thing to be checked and documented before you do anything. Even if the patient is bedridden, it has to be checked by sight. Slit lamp examination for any anterior segment damage which is there. Pupillary examination for RAPD to see whether there is any optic nerve injury. Applanation tension is obviously avoided in closed globe, while in open globe, while in closed globe it should be checked. fundus examination depends on media clarity, and I will come to that a little later. And the investigation, X-rays are not very commonly used. The CT scan is a preferred technique, and we'll come to again in detail about it. Ultrasound B scan has been dealt in detail in earlier topics. So basically, I would like to show you about the surgical correlation of the assessment and investigation, so as to it will help us in understanding what to look for when we are seeing these patients. So coming to fundus examination, if the media is clear, we can see the common presentations, that is Berlin's edema, choroidal tear. There might be a secondary CNVM if it's a long-standing trauma. There might be a traumatic macular hole, or retinal dialysis with or without retinal detachment, and optic nerve, optic disc avulsion rarely. In cases of penetrating ocular trauma, rarely we might be able to see fundus if there is an intraocular foreign body which has spared the lens. So Berlin's edema, this is not an edema. This is transient whitening of the retina because following blunt trauma. It is usually associated with outer segment injury or of the photoreceptors, as we can see here in the OCT associated. Choroidal tear, again, if it is running through the fovea, as in this patient, we can see that there might be a significant vision loss, where in the OCT we can see the choroidal tear along with the subretinal hemorrhage in the subfoveal space here. This is a patient with old trauma about 6 months back who presented with vision loss, where we can see type 2 membrane treated with anti-VEGF. A traumatic macular hole might be seen here. Once it is treated with inverted flap technique, the macular hole is closed. OCT is an effective method of assessing these patients. There is another patient of traumatic macular hole where we can see the whole edges are lifted preoperatively and there are cystoid changes. There is no PVD, as can be seen in this OCT, and intraoperatively, what does it mean? This is a younger patient. The patient doesn't have a PVD, so PVD has to be induced. This is aspiration scraper, which is used for induction of PVD. The PVD can be induced, and then vitrectomy is completed. And then here the internal limiting membrane peeling is done with inverted flap technique, where the inner ring of the ILM peeling is bunched onto the foveal area, and then the peripheral ILM is peeled. This was a large foreign body. This is one of the rare things where we can see a large foreign body on X-ray, where and we can see this huge foreign body which was lying on the retinal surface, which had spared the lens. And intraoperatively, here we can see the foreign body is about 11 millimeters long, straight metallic rod, which is lying on the retinal surface. The vitrectomy is completed. One of the sclerotomy is enlarged. An intraocular magnet by Dr. Kun is used to railroad this large foreign body out of the eye. So assessing the foreign body, assessing this case, we have to plan our surgery as well. Here, as the foreign body is removed, the lens remains undamaged and patient has got good visual outcome. When there is the media are hazy and there is absence of fundus view, we need radiological investigation, and CT scan is a preferred technique. We have to order axial and coronal scans with 1 to 2 millimeter sections, and both investigations might be required in these patients. B scan ultrasound with vector A scan, and B scans are avoided in open globe injury. It is first better to close the globe, and then in second stage do ultrasound. 10 or 20 megahertz probe might be used, as discussed by previous speakers. And looking at the extraocular, this is a large foreign body which is extraocular and intraconal, and when we are doing surgery, this is what we should expect. This is where the sclera is being closed, and then the medial rectus muscle is tagged and it is disinserted. And the foreign body can be seen lying exactly where it was seen in the CT scan. So assessing the CT scan preoperatively helps us in knowing what we are dealing with and what we have to expect intraoperatively. Here is a large foreign body. This is the next patient who's having a large foreign body with collapsed eyeball, and this is a large non-metallic foreign body in the eye. This was removed using the claw forceps that I happened to design, and this is intraoperatively after the sclera is closed and lensectomy is done. This is a large foreign body in the vitreous cavity.
The time is up.
So the vitrectomy, I'll just finish this video. So the vitrectomy is completed around the eye. The sclerotomy is enlarged and claw is used to pick up the foreign body, and then it is taken out of the eye through a large limbal section. We can see this is a large foreign body here. I'll just, this was a patient with dislocated lens and perforating trauma. Here we can see this lens, and there is a lens which was seen in the previous ultrasound, and there is area of incarceration in the vitreous which can be seen. I'll skip through this video, and just to conclude, there is something called the ocular trauma score, which was proposed by Kuhn, which gives the raw points depending on presentation and final calculation. It helps in prognosticating the case. So to conclude, I think we have to do a detailed and meticulous examination of a severe ocular trauma, and it is used important in the aim of evaluation is to treatment planning, surgical planning, and correlation, prognosis, and counseling the patient. Thank you all for patient listening.
Thank you very much, Dr. Manish. That was a brilliant presentation. We would come back to you with questions after we hear the other two speakers. Our next speaker is Dr. Deansh Mishra, who's a consultant vitreoretina and ocular oncology of Shankara Group of Eye Hospitals, Bangalore, and a very capable surgeon of repute. He's going to take us on to an interesting topic, retinoblastoma.
Thank you, man. Can I have the screen share? Tech team, can I have the screen share?
So you will have to do the screen share.
Do the screen share.
Okay, I've got it. Okay.
The bottom green, yeah.
Yeah. Okay. So is my screen visible? Hopefully I'm audible too.
Yes.
Yeah. So thank you AIOS, thank you ARC, thank you Dr. Srinivas and Dr. Chitra madam for giving us the opportunity to present. So my topic for today is how to approach a case of retinoblastoma. So I would be covering the topic in this subtopics. The first and foremost is the history. So if you get a case of retinoblastoma, we should ask regarding the antenatal history, whether the mother had any illness, any drug intake or vaccination which she has taken before. Birth history, like whether the child is mature, premature, type of delivery. Postnatal history, like at the time of presentation, what was the age, and history of trauma, squint, or any other illness which the child is having. Most importantly, we should ask for is the family history, because if the parents are having retinoblastoma, the risk of having the retinoblastoma in the child is also high. What complaints the child can present with? The most common complaints are leukocoria or strabismus, as you can see in this child. The other uncommon ones are hyphema, vitreous hemorrhage, ocular inflammation. This can also mimic ocular inflammation or retinoblastoma. Hypopyon, which can be either mobile or non-mobile, which would be seeding into the anterior chamber, the non-mobile ones. It can also present as pseudo-orbital cellulitis in certain cases. And yes, very rare presentation, we can see this fungating mass coming out of the eye or the whole eye getting proptosed. This is called as extraocular retinoblastoma. So when we are examining the child, what all should be looked at? So as we can see, the child has to be comfortably seated either in parent's lap or either the child should be made to lie down. We should try to identify the origin of leukocoria like cornea, lens, or other things. Anterior chamber, if we are evaluating, we need to try to identify if it's having hypopyon, nodules, that may be either retinoblastoma nodules, neovascularization, or if the lens is having cataract, or what kind of reflex it is. Is it a white reflex or a yellow or orange reflex, which is called as xanthochoria? And most importantly, when we are doing an indirect ophthalmoscopy, yes, the child are uncooperative, but at least we should try to identify the posterior pole, the disc and macula, if there are tumors over there. If the child is old enough, we can try to indent, because the retinoblastoma can present as peripheral tumors, as you can see over here. Investigations which should be done in retinoblastoma, yes, the most common investigation which most of us ophthalmologists would have is a B scan, where we need to look at calcification or a tumor mass arising from the retina. The other investigation which is of choice is an MRI. If it's a unilateral retinoblastoma, what all needs to be seen in MRI? We need to personally review the films to look for optic nerve involvement or extraocular involvement, and yes, the confirmation of diagnosis. If the child is having a bilateral retinoblastoma, except what we have discussed earlier, most important is to rule out the trilateral retinoblastoma in a bilateral case. CT scan is not a choice of investigation in retinoblastoma, because we have to avoid the high radiation because of the CT scan. That can be a risk of having secondary malignancy. What are the differential diagnoses? The most common differential diagnosis of retinoblastoma is the Coats disease. Retinoblastoma presents in early decades, like less than 5 years. It is mostly bilateral. Coats is usually present in the first decade, 2 to 10 years of age. It is usually unilateral, and vitreous seeds are common in retinoblastoma. The reflex, or the cat's eye reflex, as we can see in the lower image, it's white in cases of retinoblastoma, and it's yellow to orange in cases of Coats disease. And vascular formations, malformations are more important. Even if the retina is completely detached, as you can see, those vascular malformations can very well not be missed. Other important things are the calcium. As we can see, either a CT scan or an MRI or a B scan would show more calcification, except in cases of Coats, it would not show calcification, it would show cholesterol. And most importantly, when we are doing a clinical examination, we can see that in retinoblastoma, there would be a blood vessel which would be entering into the tumor cavity, as compared to a Coats, which we would see subretinal yellow exudates, which are cholesterol, and the blood vessels would be going above it. Other important differential diagnoses are ROP, or retrolental fibroplasia, where the history of prematurity would be there, NICU stay, oxygen, total RD would be there, but there would be no calcification. It can have a developmental or congenital cataract, where the eye would be coiled. No mass lesion or no calcification would be found out. Some retinal complications like FEVR, or a familial exudative vitreoretinopathy, which can have subretinal hard exudates, fibrous proliferations all over. It's mostly bilateral and have very high predilection for siblings which would be affected, which can be screened, or either an FFA would be done to identify early cases. PHPV is the again a next differential diagnosis, where we can see a sectoral cataract and a stalk extending from the disc to the lens. Endogenous endophthalmitis, which can be a mimicker, where there would be circumciliary congestion, no calcification which would be seen, and yes, complicated cataract can be there. So the non-dubious ones like choroidal cholioretinal coloboma, which can be there, which can have iris colobomas also, usually involving the infero-nasal side. And yes, toxocariasis, where history of PET exposure would be there, and there would be a peripheral granuloma, what we can see over here, and a peripheral granuloma causing a tractional retinal detachment, which can be made out. In cases where we think of patient is having a retinoblastoma, we need to do an examination under anesthesia. As we can see, when we are evaluating a child, we need to examine the anterior chamber, posterior chamber, and the lymph nodes, face, and other areas to look whether the patient is having complications associated with the retinoblastoma. And retinoblastoma, if it is associated with seeds, vitreous seeds, subretinal seeds, like that. The classification which is most commonly followed right now is the ICRB classification, where group A means a less than 3 mm size of a retinoblastoma, as in this case we can see it can involve posteriorly or peripherally. B, which is a bubble retinoblastoma, more than 3 mm of size with minimal SRF around it. C, which can have circumscribed or subretinal or preretinal or vitreous seeds which are along the tumor mass. Or D, which can have diffuse seeding, as we can see over here in this case, where a retinoblastoma is there and the tumor is having multiple preretinal and subretinal seedings in different areas other than the tumor mass lesion. E, which is massive retinoblastoma necessitating enucleation, like tumor involving more than 50% of the globe, or neovascularization of the anterior chamber, vitreous hemorrhage, or the tumor itself presenting into the anterior chamber. Very rarely we can have diffuse infiltrating retinoblastoma, where there would be a very small mass in the pars plana or pars pliccata, which presents again and again as recurrent anterior uveitis or a mass in the anterior chamber. Yes, the next thing is what can be done if you identify that as a retinoblastoma. So early retinoblastoma can be lasered. You can use your green laser, which is available, or other the most common used laser is the red laser, which is for a short wavelength, long duration laser, which is called as a transpupillary thermotherapy, where it gives more heat as compared to the coagulation, and that is how the tumor is treated. If the tumor is far peripheral and small, a triple freeze thaw cryo can be done for it. If the tumor is having vitreous seeding, either a vitreous dust or cloud, we can give intravitreal chemotherapy agents like topotecan or melphalan. And there can be other types of seeds like spears, which we can see. Larger retinoblastomas can be treated with systemic chemotherapies. And yes, the most recent, most in vogue kind of a treatment is the IAC or intra-arterial chemotherapy, where the chemotherapeutic agents are injected very close to the ophthalmic artery. The local radiation, if we have the availability of either a ruthenium plaque or an iodine plaque, a plaque brachytherapy can be done, or an external beam radiation can be done. But yes, last but not the least, if it doesn't respond, enucleation can be done for such cases. Most importantly, if the child is having a bilateral retinoblastoma, we should make the parents sit together, discuss, counsel regarding sibling screening and their future conception if they are planning. Try to do a genetic analysis for the child, try to identify the gene mutation, and if they are planning for a second baby, try to explain them regarding the risk and do a chorionic villus biopsy. Yes, whether metastatic evaluation needs to be done. So we need to look at risk factors. If it is intraocular, you need not. If it's extraocular, like optic nerve invasion, extrascleral or intracranial involvement, metastatic workup like bone marrow biopsy or bone scan or CSF tap needs to be done. Children with retinoblastoma do have very good vision. As in this case, we can see the child can have 6/6 vision or yes, 6/9, depending upon where the tumor is. If the tumor is involving the macula, also the child can have mobile vision. Even larger tumors, the vision can be good enough for the child to be mobile. In group D, eye can be salvaged, and yes, as we can see over here, the vision can be good enough for the patient to move around. Ocular aesthetics, yes, very important. Once you have enucleated, as the child grows, the processes needs to be changed. Cosmetically, it is very important because it affects the patient's psyche. Yes, last 2 slides, please. Yeah. Re-examination. When should we re-examine the child? Yes, if the child is having retinoblastoma, it has to be followed for the life because of risk of secondary tumors. Sporadic tumors, at least 5 years of follow-up are required, where post-disease regression 3 months for the first year, then 6 monthly for 2 years, and then beyond that yearly for 3 years. So what all we have discussed, how would we approach a case of retinoblastoma? History, family history, red flags, very important, examination, slit lamp, IDO, investigations like USG, MRI, rule out other mimickers of RB. If you have identified an RB, classified in ICRB, and depending upon whether it is a local tumor, treat with different modalities which are available, local, focal, systemic, EBRT, brachy, enucleation, sibling screening, genetic screening, metastatic workup if it is required, and salvage the vision. Yes, the children do see. Cosmetic rehabilitation is very important and follow-up. Thank you. Thank you again.
Thank you very much, Doctor, for a very thorough information in your 8-minute talk. It's amazing.
And the mnemonics and this thing he has used, I think, which will help the postgraduates to remember it very well.
Thank you. Yeah.
Wonderful job, Divansh.
Wonderful.
Thank you. Thank you for the opportunity. Thank you.
Our last speaker in this session and webinar is Dr. Namit D'Souza, who's going to be delving in central serous retinopathy. He's a consultant vitreoretina and diabetic retinopathy specialist from Mangalore Retina Care. On to you, Doctor.
Thank you, madam. Thank you, Dr. Srinivas, for giving me this opportunity. So last but not the least, I'll be presenting about central serous chorioretinopathy, which is one of the commonest disease which we see as ophthalmologists. So it is characterized by serous retinal detachment, most commonly involving the macular area. It is commonly seen in youngsters between the age of 30 to 50 years. It has a male preponderance, and it is seen bilaterally in about 14 to 30% of these cases. So it comes under the family of pachychoroid disease spectrum, and they share common typical features such as increased choroidal thickness, dilated outer choroidal vessels, attenuation and thinning of choriocapillaries and middle choroidal vessels. So coming to the risk factors, there are a lot of risk factors which are implicated in the development of central serous chorioretinopathy. Basically, the main important risk factors are endogenous and exogenous steroids, which can be intravenous, oral, intra-arterial, or any form of steroid, any amount of duration is implicated. Type A behavior, aggressive personality, people with gastroesophageal reflex disorders, pregnancy, sleep disturbance are implicated in the position of CSR. All these have an increased, all these risk factors increase the sympathetic activity. They release the catecholamines and corticosteroids, which have receptors on the choroidal vasculature, and this increases stimulation of this increases the choroidal vascular permeability. Now, if you see this right side lower picture, this is a scan of a classical CSR. You can see that the choroidal vasculature is almost normal in consistency, whereas if you see the upper picture, the choroidal vessels are dilated. These dilated choroidal vessels, they press upon the adjoining choriocapillary layer and they cause ischemia, damage to them. They increase the hydrostatic pressure, thus causing aggression of fluid and thereby resulting in central serous retinopathy. Now, based on the duration and RP changes, CSR is basically classified as acute and chronic. Chronic, we see a lot of RP degeneration, tracts, shallow SRF and skytic spaces. So clinical course is usually these acute CSRs are self-resolving in 90% of the cases. However, 2 to 9% they end up being chronic, and recurrence is usually seen in about 30 to 50% after 1 year. So symptoms, as you all know, they come with, the patient comes with blurred vision, central scotoma, metamorphopsia, and when we do a refraction, there is a hypermetropic shift. Now, diagnosis is very straightforward. It is clinical, but always remember to do a OCT also when he comes during the first visit, because subtle changes can be seen by OCT, and you can quantify this subretinal fluid while doing the OCT, and it will help in the follow-up whether it is decreasing or it is increasing or remaining the same. Now, FFA is not done at the first visit unless you are contemplating treatment either by laser. Now, coming to the fundus picture, how does it appear? On a slit lamp, 90D slit lamp biomicroscopy, there is an absence of foveal reflex. There is a round, oval, well circumscribed area of SRF that is seen in the center of the macula. The blood vessels are usually elevated at the margins. So, as the CSR advances, this is an acute CSR which is seen after a month. There will be some yellowish deposit which are typically fibrin proteins. These cases are likely to convert into chronic CSR. Now, the chronic CSR have a lot of RP disturbance in them. You can see that the SRF is extending beyond the inferior arcade, and there is a lot of RP disturbance. You can see in the lower picture, there are a lot of RP tracts also that are seen. Coming to other forms like bullous CSR, it is an atypical form. It, as the name indicates, it is associated with exudative detachment, and it's commonly seen in people who are on oral steroids. Also, you can typically see subretinal fibrin. You can see it under the superior temporal vascular arcade, and while doing an FFA, you will get multiple leaks. So, what do we see? What do we get to see while doing FFA? What information you will get is that of a leak. We can know the area of leak in order to do the laser, and we can also know about the chronicity of the CSR, and also know the RP changes that are associated with it. Also, secondary CNVM, which we have missed during our clinical examination, can be found. So, what do we see in a FFA in a typical CSR? This is a FFA on top of the my slide is a FFA of a typical CSR, which is typically pinpoint fluorescence, which increases in size and intensity. It is called as the in-plot appearance. It is seen 90% of the in 90% of the cases. Lower down, you can see the smokestack appearance, which with the pinpoint appearance, it becomes vertically displaced, and then it goes horizontal, just like a mushroom shape, and it is called a smokestack. So smokestack is seen in 10% of the subjects, and you can see associated dot hyperfluorescent with window defects, telling us that the CSR is in chronic nature. So FFA in chronic CSR we can see a lot of early window defects that show us in this FFA. We can see a lot of window defects suggesting that there is a lot of RP damage. Now, it is always a good idea whenever you have an autofluorescence to do it, because it tells us the vitality and the health of the RP. You know that lipofusion, RP contains lipofusion, and that is that's why the RP is damaged here, and that's why it shows a hypoautofluorescence. You can see the hyperautofluorescence at the margin of the CSR, which says that there is overactivity of the surrounding RP cells. Now, coming to the OCT findings, which already has been discussed, you can see that this is a OCT of a classical CSR, wherein there is an elevation of the ellipsoid zone, and what is pushing it is a subretinal fluid, which is hypo-reflective, and you can see lower down there is a serous PD, which you see in 70% of the cases of CSR, which is also hyper-reflective. Now, coming to chronic OCT and chronic CSR, you can see that there is this is a OCT of a chronic CSR where there are hyper-reflective dots suggesting the photoreceptor damage, and with time it becomes accommodated. And on clinical examination, these are seen as yellowish dots. So, what are the red flag signs in CSR? So, hemorrhage is one red flag sign. Always, never CSR is associated with hemorrhage. Whenever there is an hemorrhage, always do an FFA or ICG and rule out CNVM, because the treatment is completely different. Fibrin CSR, sometimes fibrin CSR can mimic CNVM because of the sheer creamish color that it has. So we had a doubt, and we had to clear by doing a fundus fluorescent angiography, which showed us this pinpoint leaking hyperfluorescence, which suggested it to be a CSR. So in this typical patient, we did also a OCT, which showed the vacuole sign, which has the central hyporeflective area surrounded by a hyperreflective area because of the fibrin being displaced by this egress of the SRF. So also you can see there is a break in the RP also. You can also have double layered sign, which shows hyperreflective, which can be hyporeflective or hyperreflective. Hyporeflective double layer sign is typically seen in CSR. We are not worried about it, but when it is hyperreflective, we can say that it is associated with CNVM. Now, differential diagnosis. There are a lot of conditions which mimic these CSR. It can be optic dysplasia. That's why it's a good idea to look at the optic nerve to know whether there's an optic disc also. AMD and PC, which I've already discussed, can be differentiated by doing a FFA or an ICG. Inflammatory conditions such as VKH can be differentiated. Sometimes they have VKH have posterior pockets of focal SRF. They can mimic CSR. It can be differentiated by doing a FFA. In posterior cellulitis, they can be posterior pockets which can be differentiated by doing ultrasound. And also, certain times there are intraocular tumors which wherein an ultrasound, like for example, a choroidal mass which pushes and causes serous detachment, which can be differentiated by doing an ultrasound. So treatment is very straightforward. Acute CSR is a self-limiting condition. We can always wait, manage conservatively. First episode, manage conservatively. Take a good history of medications, that lifestyle changes, counseling, and also OCT has to be done every month. Now, this is a flow chart of how we manage acute CSR. Acute CSR always treat conservatively, do an OCT, repeat OCT every month. If it's improving, follow him up until the every month until the SRF resolves completely. If there is no improvement, of if you are seeing an increase in the SRF, then we should proceed with an FFA. Now, FFA can show us a leak, where the leak site of the leak is. If the extra leak is extrafoveal, we are very happy. We can do a mild laser here by doing using a thermal or a green laser, and the SRF just disappears in a few days' time. Whereas when it's subfoveal, we are in trouble because doing a laser with a green laser can cause scars and decrease in vision. So the only choice is PDT, photodynamic therapy, or micropulse laser, or epinodone medication. So intravitreal anti-VEGF is only resolved in case of secondary, reserved in case of secondary CNVMs. So there are a lot of medical medicines that are available and tried out. But what is of most importance is the eplenorone, which is a selective mineralocorticoid receptor antagonist, which acts on the receptors on the choroidal vasculature. It decreases the vascular permeability and thereby resolving the CSR. So the common side effects are hyperkalemia. That's why we have to do a 15-day checkup of his blood electrolytes. Finally, CSR is a complex disease. Multimodal approach and a holistic approach is required for its adequate treatment and to get back the patient's vision, lost vision. Thank you very much.
Thank you. Thank you. So, Srinivas.
Yeah, thank you, Dr. Namit. Wonderful presentation. Can you just stop the screen share?
Very extensive talk.
A panel discussion. We'll start with Dr. N.S. Muralidhar, sir. You have points to add. I'm sure there are 4 talks and you must be having a few more points and suggestions from you. We would like to listen from you, sir.
No, I think all the speakers have taken a lot of effort to put together all the points very well. You know, I have very little to add. In fact, I think Dr. Deepthi Kulkarni made very good points in terms of diagnosis of ARN and how urgent it is to treat them, because it's a rapidly progressive disease. You know, all types of viral retinitis, whether it is CMV retinitis or whether it's a porn or ARN. Urgent diagnosis is very important, and she stressed that it's a clinical diagnosis and it has to be substantiated by, you know, taking the fluid from the AC or vitreous and getting the PCR, you know, diagnosed and a timely treatment. And Dr. Divyansh outlined the management of retinoblastoma very well. I have nothing much to add because I don't do retinoblastoma. And Dr. Namit D'Souza nicely summarized the current status of the CSR. In fact, one of the most common comments made by fellows when they join our hospital and work for some time is that they all thought that CSR is a very simple disease to treat. But then once they start seeing the chronic cases and difficult cases, they find it extremely, you know, it's a complex disease. And today the management, you know, is not so easy. We have to look at multimodal imaging and also look at the other differential diagnosis that he highlighted very well. And Dr. Manish Bapai, you know, really showed very challenging situations in the posterior segment so well, especially the foreign bodies and you know, how he manages them. And he also highlighted the importance of examination of the posterior segment. All the speakers have taken a lot of pains to you know, emphasize the salient points. You know, I think they did a very good job.
Dinesh sir, thank you, Muralidhar sir, for contemplating.
I agree with Muralidhar. Actually, there's very little to add to this. You've actually more or less provided an entire book of all these conditions. And so, I mean, I frankly speaking, I don't think there's much to say. It's only a question of now assimilating this information, because there's a lot of information, and how this gets assimilated. And when you present it, you have to know that you present only the salient features. Like, for example, there may be hundreds of differentials, but just the first 3, 4 are the ones which are relevant. And the rest depends on getting if the examiner wants to ask you something. Don't provoke the examiner into asking you something which you know very little about. That is the first lesson about any exam is don't push the examiner into those areas where you know less. So stick to, sometimes better to speak less and respond to whatever you're asked.
Thank you, sir. Jatinder sir, you're muted.
Unmute yourself. Jatinder,
I would just like to congratulate everyone. Very nice talks. Particularly impressed with the last session of the talks. Very nicely presented. Very holistic approach. Some points are here and there, but I think we are running quite late. I think everybody wants to get back to their routine. Thank you so much, everyone, and thank you, ma'am and Srinivas, for letting me be a part of this.
So I think I should come to my conclusion remarks. I mean, it goes without saying that these 2.5 hours have been a brilliant learning webinar. And would you believe it, being a completely anterior segment surgeon, I heard every bit of all that you all spoke, though I don't know how much I'm going to remember, but I would definitely appreciate your quality of work a lot more henceforth. On behalf of ARC, a special thanks to our expert panel, and of course, the wonderful sessions which are so beautifully put together by Srinivas Joshi that made it all the more interesting. Our thanks are always due to our AIOS admin, which are headed by Mr. Kripal and his team. Mr. Sunil, who's our webinar admin, you must have seen how minutely he associates with each of these webinars and keeps a tab on our time and duration of talks. Sai and Manjula, who do all the background work for ARC, and they definitely help in leading ARC forward. Our deep thanks is to be expressed to Entode with very, very great conviction, because every single webinar which I've conducted from the beginning of my tenure to now has been sponsored by Entode, and I'm deeply grateful to them. And finally, most importantly, the only thing which eggs us ARC team forward is the attendees number, which I keep bothering Mr. Sunil to tell me at the end of the show. And I would definitely update you too. It is really, truly encouraging to have so many of them attending. Even now, there were some 300 odd still there, and we started off with very good numbers. Thank you, one and all of you, because it's you who makes these webinars so useful for us. Thank you.
Can we just pose for a photograph, madam, for the ARC filing?
Yes. So few of us. Okay. Smile.
Sunil, can you just take a picture? Yeah, Manoj sir.
Sunil?
Yeah. 1, 2, 3, click.
Thank you.
Great. Thank you. Thank you so much for the patient. Thank you very much.
Thank you, everybody. Thank you, ARC.
Thank you, everyone.
Thank
Good
you,
night.
Srinivas, and thank you,
Thank you all
for the wonderful webinar. Good night, everyone.